So yesterday we have finished with the Cushing syndrome. Okay. Okay, so yesterday we have finished with the Cushing syndrome. Okay, we have discussed the cause of it. Four causes we have discussed: either the exogenous, either the this hyperplasia or the cancer, or the ACTH secreting pituitary adenoma, or might be a paraneoplastic ACTH secretion. We have discussed how to differentiate between them. In upper two scenario where you have taken the exogenous corticosteroids, or there might be a cancer of the adrenal glands, there would be a loss of ACTH, right? And whenever you have a low ACTH along with the Cushing syndrome symptoms, then you will always do the CT or MRI of the abdomen to make sure, to know whether it is a atrophy or the hyperplasia of the gland. Second thing is the ACTH secreting pituitary adenoma, or might be a paraneoplastic ACTH secretion. In both these scenarios, you will have a high ACTH levels, okay, which cannot be suppressed by giving the low dexamethasone, okay. Whenever you give the low dose of dexamethasone, if this ACTH is suppressed, that means it is not a cancer, it is not a ACTH secreting this cancer, right? But whenever you give the patient low dose to dexamethasone and these ACTH levels are not suppressed, that means it either could be a Cushing's disease or it could be a paraneoplastic ACTH secretion. Okay, and to differentiate between them, you need to give the patient high dose of dexamethasone. When you give them high dose of dexamethasone, if the levels of ACTH are suppressed, that means it is also this Cushing disease. If the levels of ACTH are not suppressed, that means it is the paraneoplastic ACTH secretion. We've discussed the causes of it. Then we have discussed all over these all symptoms. Okay, we have discussed that there will be a central obesity present and the peripheral muscle wasting would be there. So you will get the moon faces, you will get the hump on the back, you will get the this frontal obesity, right? You will get the peripheral muscle wasting, okay, in which you will have a weakness and atrophy without any pain. The CK levels are normal, okay. You will also get the osteoporosis and the poor wound healing, okay, because these because the cortisol inhibits the fibroblast and as well as it will also suppress your inflammation, and both of these things are needed for the proper wound healing, okay. So that's why you get these things, the poor wound healing, okay. And we have discussed a Nelson syndrome. We have discussed how a ACTH pituitary adenoma will increase in size and will make the symptoms worse if you remove the adrenal glands. Okay, because at some part these adrenal glands are providing negative feedback to this cancer and maintaining the ACTH levels. As soon as you remove the adrenal glands bilaterally, what's gonna happen? The levels of ACTH will suddenly rise, and that can cause the hyperpigmentation. The size of the pituitary gland will increase, the tumor will increase, and you will get the mass effects like the headache, bitemporal hemianopia. And this is known as the Nelson syndrome. The treatment would be to remove the tumor itself. Okay, it could be a transplanted dressing, it could be a post-operative pituitary irradiation for the residual tumor. Okay, and now we will discuss the adrenal insufficiency. Okay, before doing that, we need to also discuss the hyperaldosteronism. After that, we will discuss the insufficiency. Okay. Okay, so what is the hyperaldosteronism? In which you have a hyperplasia of the zona glomerulosa. So they will secrete the aldosterone. Okay, and the features, because you know that aldosterone will act on the DCT. In the DCT, uh, the aldosterone is a part of RAS system again, and the DCT it will cause the reabsorption of the sodium and causes the loss of this potassium. So what you're gonna have is the loss of potassium. So you will have a hypokalemia. Okay, you will have a metabolic alkalosis because of high reabsorption of the bicarbonate also, right? So we'll have a metabolic alkalosis. You will have the low level of potassium. Because of the sodium and water reabsorption, you will have a hypertension. Okay, but sodium levels will be normal. Okay, because you're absorbing water along with the sodium. Okay, so these levels would be initially normal. Okay, but now what's gonna happen? You will have the aldosterone escape mechanism. In this mechanism, we have discussed that one, the RAS system is inhibited whenever the high aldosterone count is there. Okay, and second thing would be the ANP and BNP release. And because of that, you will always get the aldosterone escape. Okay, But in case of a secondary causes of the hyperaldosteronism, where you have a RAS activation, where you have too much activation of the RAS, and as a result, too much activation of the aldosterone. In that case, you do not have any aldosterone escape mechanism, right? And in that case, you will have the fluid overload, and that can lead to the heart failure. Very important. Okay. So for the primary hyperaldosteronism, you will have the adrenal adenoma, also known as the Crohn's disease. You will have the bilateral adrenal hyperplasia. Okay. You will have a high aldosterone and low renin. Okay. Because of the negative feedback, you will have the low renin, and this low renin will make sure the aldosterone mechanism will be remain, right? And it leads to a treatment-resistant hypertension. Very important. You will have a sodium levels normal. You will have a low potassium. You will have a high urine potassium. Edema won't be there. This is an important thing. You won't have any edema because of the ANP, BNP release from the heart. And second thing, because of the renin inhibition. If you have a secondary hyperaldosteronism, which generally happens whenever you have a renin secreting tumor, okay, so this can lead to the volume overload, and this can lead to the edema. So you will have a nephrotic syndrome, you will have the cirrhosis, you will have the heart failure. Okay, very important. So a renovascular hypertension would be there. Okay, and so step one will also ask you what are the symptoms of the hyperkalemia, or they can ask you what are the symptoms of the hyperaldosteronism. So make sure symptoms are because of this low potassium levels, because edema won't be there, and all the symptoms gonna be because of this low potassium levels. And these are the muscle weakness, paresthesias. Very important. Okay, muscle weakness and the paresthesia. You will also get the hypertension and metabolic alkalosis because of high bicarbonate. Okay, very important. So any doubt on the hyperaldosteronism?
No, thank you.
Okay. Then comes the adrenal insufficiency. Okay, in which you have a low cortisol, low aldosterone, or low steroids. Okay, now what's gonna happen? Uh, in this scenario, you will have a low levels of everything, the mineralocorticoids and the glucocorticoids. Okay, so first you need to know the symptoms of this adrenal insufficiency. It would be the weakness, fatigue, orthostatic hypotension. Why? Because you require the cortisol for the beta receptors and the alpha receptors this proliferation, right? So so without the cortisol, you won't get the maintenance of a normal BP. So you will get the orthostatic hypotension. You will get the muscle pain. You will get the weight loss. You will get the GI disturbances, which includes the abdominal pain, nausea, vomiting. Okay, because of the salt wasting, the patient will also have a salt cravings. Very important. So step one, whenever they give you a patient with a history of a hypotension, yeah, shock, okay, with nausea, vomiting, abdominal pain, sometimes fever, weakness, okay, and along with any salt cravings, that 100% mean that this is a case of adrenal insufficiency. So fever, nausea, vomiting, abdominal pain, along with the hypertension and shock. Just remember these 5 points. These are the main symptoms for the adrenal insufficiency. Okay. What is the function of the aldosterone? It is to maintain the blood volume. Okay. Whenever the sodium levels are dropping, potassium levels are rising. Okay, it will lead to the uh, increase in the aldosterone, and that will maintain the blood volume, right? But in case of hypoaldosterone, what's going to happen? You will losing your sodium. Okay, you will have a high potassium level. Your blood volume will be low, very much low, and because of this low blood volume, the oxygen supply to the tissues will be also decreased, and what you will get is the weakness and fatigue. Okay, you will also get the muscle pain. Very important, because of low blood volume, low blood flow, you will get the muscle pain also. Because of this low cortisol, you will have the low glucose. You will also get the hypoglycemia. Okay, you will get a very low vascular tone, because you know that cortisol is required for the 100% action of epinephrine on epinephrine. So you will get the orthostatic hypotension. Okay, and treatment, the glucocorticoids, they should be as soon as possible. You need to give the patient glucocorticoids without waiting for any kind of lab results. Okay, whenever you encounter a patient with a hypotension and shock along with this fever, nausea, vomiting, okay, and muscle pain, you will immediately give them the glucocorticoids without waiting for any lab result. Okay, giving the dopamine, epinephrine or non-epinephrine, they won't help. Why? Because we still require the cortisol. okay, for their action. So even if the patient is having a shock, you cannot give them the epinephrine or norepinephrine because cortisol won't be there, okay, for the permissive action. This is the important thing. Okay. Then discussed about the primary adrenal insufficiency in which you have a gland, glands dysfunction. Okay, so that you will have a low cortisol level, you will have a low aldosterone level. And like we have discussed, you will get the hypotension, you will get the hyperkalemia, you will get the metabolic acidosis. Why? Because of loss of bicarbonate. Okay, and because it is a primary insufficiency, so you will have a high ACTH, and because of the high ACTH, you will have the skin or mucosal hyperpigmentation, because you know that along with the ACTH, MSH, and endorphins, they also be released, right? Because they all are the product of POMC. Okay, you can get an acute insufficiency and you can get a chronic insufficiency. For the acute insufficiency, it would be a sudden onset of all of these symptoms: fever, shock, nausea, vomiting, headache, weakness, muscle pain. These all will be the very sudden symptoms, right? Acute symptoms will be there. Okay, it can be happen because of a massive hemorrhage. If you guys remember the Neisseria meningitis, we have discussed how this Neisseria meningitis will enter bloodstream, will go to your brain, and after the brain, it will reach to your adrenals, and there it can cause a bilateral adrenal hemorrhage. And because of this bilateral adrenal hemorrhage, the patient can have a Waterhouse-Friderichsen syndrome, right? So for the Neisseria meningitis, especially, it would be a case of the DIC shock along with the meningitis. So this is the acute cause. Okay, if a patient, see like that. Okay, and so patient present with the shock and the acute adrenal crisis. Second thing is a chronic Addison's disease. Okay, which generally happen because of the atrophy or the destruction. So it could be an autoimmune destruction. It could be an exogenous type. Whenever the patient is taking exogenous glucocorticoids, okay, and they suddenly stop taking them, okay, then what's gonna happen? The patient can have an acute crisis. Okay, or whenever the patient is having these glucocorticoids in their therapy, okay, and they undergo any kind of infection or any kind of surgery, then you must increase the dose of these glucocorticoids, because in case of any stress, okay, you require more cortisol, more steroids, right? And if you do not increase the dose, then you can end up having the acute crisis. So very important, whenever the patient is having any acute infection or a medical procedure, okay, normally the glucocorticoid this production will be increased in your body, right? But the patient who are having this adrenal insufficiency, who are on this therapy, the glucocorticoid therapy, the dose must be increased. Okay, if you won't increase the dose, the patient can end up having the adrenal crisis, and that can lead to the death. So if you encounter a patient, okay, who is undergoing the surgery, okay, and while making the section, okay, while making the cut, he suddenly dies. Okay, so this might be a case of adrenal crisis, and why this happened? Because you failed to increase the dose of the glucocorticoids. Okay, and the chronic one, it is for the autoimmune diseases, which is the most common one, and the TB is a very common in the developing worlds. Very important. TB is the most common in the developing worlds. Whenever the systemic tuberculosis happen, it can reach to your glands, the adrenal glands, and there they can cause the insufficiency. In case of the all the in case of Western worlds, it would be the autoimmune destruction. Okay, so for the primary adrenal insufficiency, you will always get the hyperpigmentation. As you can see, this is the mucosal hyperpigmentation on the gums. Okay, you will get the hyperpigmentation of the lips. You will get the hyperpigmentation of the skin. Okay, very important. So any doubt on the primary adrenal insufficiency?
No, thank you.
Then comes the secondary adrenal insufficiency, in which your glands are absolutely normal. It just has stimulatory signal, which is by the ACTH is not there. Okay, so it is seen in the decreased pituitary ACTH production. So if there is no ACTH, there won't be any hyperpigmentation. Okay, and because this ACTH, it do not control the zona glomerulosa, that means the aldosterone levels would be normal. In this scenario, you will just have the deficiency of cortisol and other steroids. Okay, mineralocorticoids are absolutely normal. Aldosterone levels are absolutely normal. You will have an intact RAS. You will have a normal sodium level. You will have a normal potassium levels. Okay, so do remember this thing, right? no pigmentation, no sodium loss, no high potassium levels, intact RAS. This is what the secondary adrenal insufficiency. It generally happens whenever a metastasis happen to your this pituitary, or you have a pituitary tumor which is non-segregating type, which is disrupting the parenchyma of the pituitary, right? Or other causes of the hypopituitarism, which we have discussed earlier, the Sheehan syndrome, right? And the pituitary apoplexy and the Empty-Sella syndrome and all these things, they are all can lead to the secondary adrenal insufficiency. Okay. Then comes a tertiary adrenal insufficiency, okay, in which you have a exogenous steroids. This is the tertiary adrenal insufficiency in which you have a exogenous steroids. Now, because of the exogenous steroid use, they will inhibit the ACTH as a negative feedback. And ACTH cannot stimulate the adrenal glands. It cannot maintain the adrenal glands. So you will end up having the atrophy of the adrenal glands, right? And they can precipitate it by the abrupt withdrawal. Very important. Whenever you abruptly stop the exogenous steroids, because endogenous ones are already inhibited, what you will get is uh, the precipitation of the adrenal crisis. Okay, and the aldosterone synthesis would be unaffected. Why? Because ACTH, it do not controls the aldosterone. Okay, it just controls the glucocorticoids, right? So tertiary always happens because of the treatment. Okay, and whenever a tumor metastasizes to these adrenals, what's going to happen? They will replace a normal parenchyma with the tumor parenchyma, right? And what you will have is the adrenal insufficiency again. Okay, and it could be a primary type, okay, in which you have a high ACTH. Okay, so that's about the adrenal insufficiency and its type. And the same flow diagram is there. Okay, first we will check for the random ACTH and the cortisol, the ACTH stimulation test. Okay, this test is basically used for the to check whether my hypothalamus, pituitary, and the adrenal system is intact or not. Remember the meteropon stimulation test? They will inhibit the conversion of 11-deoxycortisol to the cortisol by inhibiting what enzyme? Does anyone remember?
21.
Not 21. It's 11-beta hydroxylase. Okay, because you already have the 11-deoxycortisol. Okay, 11-beta hydroxylase act on the 11-beta cortisol. This 11-beta hydroxylase act on the 11-deoxycortisol to convert it into the cortisol, which is an activated form. Meteropon inhibit this conversion. Okay, this conversion. Okay, and now what's going to happen? You will have a high level of deoxycortisol and low level of cortisol. So three scenarios can happen. Either the ACTH level is decreased or normal, or it is increased. If ACTH levels are decreased or kind of normal, that means there would be a secondary or the tertiary insufficiency, because the cortisol, it will be giving the positive, it will be giving the negative feedback, which means the ACTH must be increased, right? But it is not increasing, which means it could be a secondary or a tertiary insufficiency. Okay. If the ACTH levels are increased and the 11-deoxycortisol level are increased, that means my pituitary was absolutely normal. Okay, and my adrenals, they're also responding to the ACTH. That's why I'm having the 11-deoxycortisol level high. So that means a normal response to the decrease in cortisol. If you have a high ACTH but a low deoxycortisol, that means my pituitary was intact, but my adrenals, they are not responding to the ACTH, which means it is a primary adrenal insufficiency. Is that okay for everyone?
Yeah.
Yes.
And you check for again the random cortisol levels, okay, and you have a decreased random morning cortisol, okay, and with the ACTH stimulation test with a low this cortisol, okay, then you will measure the serum ACTH levels. If the serum ACTH levels are low, again it would be mean a primary or it would be mean a secondary or tertiary deficiency. If you have a high ACTH, that means it would be the primary adrenal insufficiency. So in that you will check the cortisol level, the morning cortisol. You will have a low cortisol levels, then you check for the ACTH. If you have a low ACTH along with the low cortisol, okay, that means it is a secondary deficiency. If you have a high ACTH along with the low cortisol, that means it is a primary deficiency. Just this. Okay. Is that flow diagram okay?
Yeah.
Okay, and one more thing, step one can ask you that what gonna happen to the water retention in that case. See, you are already having a low aldosterone, right? And because of the low aldosterone, you're already having a low sodium and high potassium. Above that, because of the low blood volume, you know that low blood volume or this low osmolarity, high osmolarity, these are also these are all the factors which can stimulate the ADH secretion, right? And so, because in case of adrenal insufficiency, you're having a low blood volume, the ADH will be increased, which will cause the free water retention. And because of this free water retention, you can have a worsening hyponatremia. So they can ask you about this ACTH, the ADH secretion in case of primary adrenal insufficiency or secondary tertiary in anyone. Okay, in any of the case, you will have a high ADH secretion. Very important to note because of this low blood volume. Okay, don't forget this point. You will have a worsening hyponatremia because of that. So whenever you encounter a patient with hypotension, shock, nausea, vomiting, abdominal pain, and fever, weakness, sometimes a salt craving would be there. Okay, so these are all the signs and symptoms of the adrenal insufficiency. Okay, any doubt on this page so far?
No,
Yes.
thank you.
Yeah,
I'm sorry.
do ask.
Can you please repeat the integration between aldosterone and ADH?
See,
The last point you made.
yeah. What are the factors which can stimulate the ADH secretion? You tell me.
Okay, so you secrete ADH when you need to conserve water in your body.
And what are the two factors for which I need to increase the ADH? Either the low blood volume or either the high osmolarity, right?
Okay.
Because whenever I had a low blood volume, I need to increase the blood volume, and I can do that by the ADH. Yes. Whenever
Yeah.
I have a high osmolality, I need to increase the free water to maintain the osmolality, right? And in that case, also I need to secrete the ADH. Is that
Mhm.
okay?
Yeah.
In case of aldosterone deficiency, in case of this the adrenal insufficiency, you also have the deficiency of aldosterone, right? If the aldosterone is not there, then it cannot stimulate the collecting ducts and the DCT to lose the potassium and to reabsorb the sodium, right? And along with the sodium, you will have a loss of this water also, right, in the kidney. So ultimately, you will get is the low blood volume along with high potassium. Is that okay?
Yes.
And if you're having a low blood volume, this is the stimulation factor for the ADH secretion. This will stimulate the ADH secretion, and you will have a free water retention. And this free water retention can further complicate the hyponatremia.
Okay, so in my aldosterone, your serum is still even levels, right? Because your sodium and water are being lost at the same time. So
Yes, you will have a mild hyponatremia. More sodium will be lost, no doubt. You will have a mild hyponatremia and
okay.
and this hyperkalemia. But if you're reabsorbing the free water, if you
Mhm.
retention the free water, that means it can worsen the hyponatremia, right? It will further lower down my sodium levels.
Okay, because you're diluting it down by holding in your water, but you have the
Exactly.
same amount of salt.
Yes, exactly. See, in case of like we have discussed, in case of this adrenal, whenever you have a high aldosterone, okay, it will reabsorb the sodium along with the water. That means
Mhm.
either can I can have a mild hypernatremia, very mild, or I can have a normonatremia because I'm absorbing water along with sodium. But in case of ADH, I'm just reabsorbing my water, no sodium. Okay, so it will always end up having the hyponatremia in case of ADH, right?
Yes.
That's all. Any more doubt?
One, no, I understand what you're saying here. This all makes my question, my initial doubt was clear. Do your cells, does your body try to, like, when we're talking about our ICF fluid and our ECF fluid, does your
Yes.
ICF fluid try to like give salt
Yes,
away
of course.
to the ECF?
Whenever you have a whenever you have a low osmolality, they will always lose their salt inside them.
But it's not enough.
Or-
So the aldosterone has, sorry, so there is not enough volume coming
Yes,
in.
exactly.
So
See,
that's
volume
why.
is already lost. See, volume is already
Oh,
lost. Even though the AD is there, how much water it can be retention? how much water it can be reabsorbing. The volume is already losing so much. You're
Mhm.
having a dehydration. Okay, even though the ADH was there, it cannot maintain that much volume of water, right?
Yeah.
It will try to compensate, but it can never recover. It can never recover it back to the normal again, right?
Yeah.
It will try to compensate, but can never reach to normal limits again, right? It will
Yeah.
always be lower than that.
Okay, perfect. Thank you so much.
Yes. So, any more doubt on this page? Anyone?
Yeah, Dr. Chaudhary, can you explain again? You wrote that exogenous ACTH won't increase cholesterol. Can you explain that?
Uh, where uh, where it is?
It is just above the acute infection medical procedure on the right side in the middle.
This one.
Uh, Yeah, just above that, exogenous ACTH won't increase cholesterol.
In case of a primary adrenal insufficiency, even if you give the patient this exogenous ACTH, the glands were not there, right? The glands were not working. So even
Yeah,
if you give the patient exogenous this ACTH, it won't increase in this cortisol, right? Just at
okay.
this point. Okay. Okay. So now you need to know the neuroendocrine tumors. Okay, just give me a second for that. Okay. Okay, so for the neuroendocrine tumors, these are those neoplasms which are originate from the neuroendocrine cells. So they have the traits which are similar to the neuronal cells as well as the endocrine cells, the hormone producing cells. Okay, so they have the traits which are similar to the neuron cells, the nerve cells, and the hormone producing cells. All of these tumors, they are all positive for the neuroendocrine markers, and you guys already studied all the neuroendocrine markers in the general pathology, which are the synaptophysin, the chromogranin, the neuron-specific enolase. Okay, these are the three most commonly, who tested neuroendocrine tumor markers. Okay, the chromogranin, the neuron-specific enolase, synaptophysin. Okay, other markers that you can use are the serotonin for the serotonin secreting tumors. Okay, histamine for the histamine secreting tumors, the calcitonin for the calcitonin secreting tumors. And what are the calcitonin secreting tumors?
Medullary cancer.
Exactly, medullary thyroid carcinoma. Okay, very important. So now we need to discuss what tumors can include under the neuroendocrine tumors. For the and we will go from above to below your body. Okay, so at the point you will have the thyroid gland. Okay, the medullary thyroid carcinoma in the thyroid gland, it is an example of neuroendocrine tumor. Okay, then comes the lungs. Okay, in lungs, the small cell lung cancer and the carcinoid tumor. These are the example of neuroendocrine tumor. Then you comes the pancreas. Okay, in the pancreas, the insulinoma and the glucagonoma. Okay, which is the insulin and the glucagon releasing tumors. These are the example of neuroendocrine tumor. Then you reach your adrenals. In the adrenals, the pheochromocytoma. Okay, and you can say the neuroblastoma also. These are all the example of neuroendocrine tumor. Then comes the GI tract. In the GI tract, you also have the carcinoid tumors, right? So carcinoid tumor of the GI tract and the gastrinoma also. Okay, these are example of neuroendocrine tumors. Okay, so thyroid, then lungs, then pancreas, okay, then the adrenals, and then the GIT. These five locations for the neuroendocrine tumors. And every tumor that you will study after the after this heading, okay, the neuroblastoma, pheochromocytoma, the insulinoma, and other tumors also. Whatever tumor you study after this heading, they are all the neuroendocrine tumors in the first aid. Okay, so in the GI system, the carcinoid and the gastrinoma, in the pancreas, the insulinoma, glucagonoma, in the lungs, small cell lung cancer, and the carcinoids also. In the thyroid, the medullary thyroid carcinoma, in the adrenals, the pheochromocytoma, and the neuroblastoma. These are all the example of neuroendocrine tumors. Okay. So neuroendocrine cells, they have, they kind of share a common biological functions. Okay. although their amine precursor uptake decarboxylase despite differences, it is, you can just ignore this fact. Just look for one thing, that they all have a common features, okay, but they have a different origin, they have a different anatomic sites, and they have a different mechanism of actions. Okay, they all have everything different, but their function ultimately that affects, okay, they are very much common to each other. Okay, so they all secrete the products like the chromogranin A, which we can detect, the neuron specific inulase, which we can detect, synaptophysin, which we can detect. Many of the tumors secrete the serotonin, which we can detect easily. Many of them secrete a histamine, many of them secrete a calcitonin, and we can detect every of these secreted products. Okay, what is the treatment? Treatment will be the surgical resection, and for any neuroendocrine tumor, you can always use the somatostatin. Very important. Okay, so now discuss the neuroblastoma. Okay, it is the most common tumor of adrenal medulla. See, tumor of adrenal medulla, and because you guys know that the medulla of the adrenal glands, it is driven by the by the neural crust cells, right? It is driven by the neural crust cells, and that's why it is a neuroendocrine tumor also. Okay, and it is seen in the children who are less than 4 years of age. Okay, it is originated from the neural crust cells. That's why the tumor is in the medulla only, not in the cortex. Okay, and please note, because these neuroendocrine cells, these neural crust cells, these cells are responsible for the sympathetic chain in your body. Remember, you have the vertebrae, and along with the vertebra side, you will have the sympathetic chain, right? And finally, the sympathetic chain is connected to the by some neurons to the adrenal glands, right? The medulla part of the adrenal gland, right? So because all of the sympathetic chain along with this adrenal medulla, it is made up by the neural crust cells. You can have this neuroblastoma anywhere along this sympathetic chain. Okay, you can have it here, 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 you can have it even in the neck, because you have the sympathetic ganglions in the neck also, right? So you can have this tumor anywhere along the sympathetic chain, not just in the medulla. Okay, very important to note. Okay, but the most common presentation is the abdominal distension, a form and an irregular mass that can cross the midline. And it is very important to differentiate it with the Wilms tumor. Okay, because Wilms tumor is always very smooth. It is not firm, it is not hard, it is smooth, and it is unilateral. Okay, but this tumor is kind of bilateral type. It can cross the midline, and it is very irregular and hard form. Okay, and they won't develop any hypertension, unlike the pheochromocytoma, which is also a tumor of adrenal medulla. Okay, neuroblastoma, they do not develop the hypertension. Okay, very important to note that. Okay, and one important syndrome that you get along with the neuroblastoma is the office clonus myoclonus syndrome. As the name suggests, they have the clonus, which means the irregular jerks. In the office, which the eyes, you have the irregular jerks in the eyes. You also have the myoclonus or the myoclonic seizures. So patient will be having the myoclonic seizures along with the jerks in the eye. So it would be a non-coordinated movement in the eyes and non-coordinated or jerky movements in the hands and the feet. And that's why the name dancing eyes and dancing feet syndrome. Okay. And Wilms tumor, you also won't get this office clonus myoclonus syndrome. Okay. And because these tumors are releasing the epinephrine, non-epinephrine, you will have a high HMA and VMA, okay, which are the catecholamine metabolites, okay. And very important to note, they have a Homer-right rosettes. They have the Homer-right rosettes. And if you remember, if you studied the neurology, you guys remember one tumor in which you have the Homer-right rosette, which are the medulloblastoma. Remember? Yes, the medulloblastoma. No. Okay, don't worry, you will encounter that fact later. In the medulloblastoma and in the neuroblastoma, In both the conditions, you will have the homoright rosettes. In the homoright rosettes, what will happen? You will have a in the center, okay, a eosinophilic center, okay, which is, you can say, a lumen, a central lumen, which is highly eosinophilic, as you can see if I zoom. This lumen is highly eosinophilic, and surrounding this lumen will be your tumor cells in a circular manner, as you can see. Okay, and these are the homoright rosettes. Okay, very important to note. So the same histology or the same biopsy you will see in the medulloblastoma, and the same histology you are seeing in the neuroblastoma also. Okay, they are all will be positive for the neuron-specific enolase. Okay, and they are associated with the NMYC oncogene. Remember, we have discussed that already in the general pathology section. The NMYC can lead to the neuroblastoma. What does CMYC can lead to?
Burkitt.
And what does ALMYC can lead to?
Lung cancer.
Yes. Okay, please remember this fact. And what type of lung cancer? Is it adenoma of lung?
I think so.
No, it is the small cell lung cancer. Okay, don't
Okay.
forget that. Okay, and other things, just like any other tumor, you are having a chronic inflammation, and because of the chronic inflammation, you can have the fever, fatigue, and weight loss. These three are the almost, you will find the fever, fatigue, and weight loss in every tumor. Okay, so whenever I step one ask you if the patient is having any kind of tumor, of course they will give you a history of tumor inside the patient, and they will ask you what could be the most common presenting complaint of this patient. They can ask you this. So it always going to be a fever, weight loss, and fatigue for every tumor. It is common. Okay, so you can have the fever, fatigue, and weight loss in the neuroblastoma also. Okay, so yeah, that would be it. Any doubt on the neuroblastoma?
What is Bombesin?
It is a marker of the tumor, again, just like the neuron-specific enolase. You have the marker bombesin, which is secreted by the neuroblastoma cells also. So just a marker, nothing much more. Okay.
Okay, thank you.
I have one question.
Yeah, do
Like,
ask.
why is there normotension even if the tumor is releasing epinephrine or norepinephrine?
Because of the high metabolism of this epinephrine and norepinephrine. They form
Okay.
and they will be metabolized very easily, and that's why you will having this. As you can see, they have a high the high catecholamine, these metabolites, right? So they will be forming and they'll be metabolizing very early. So no hypertension. Okay.
Okay. And like, is there any difference between neural crest cells and neuroendocrine cells?
Neuroendocrine cells belong, you can say that they belong to a neuroendocrine cell. See, neuroendocrine cells are those cells which have a common features for the neural as well as the endocrine ones. So the neuroendocrine cells, they can be included in these type of cells, okay? Because they have a feature for the neural tumors. Although different thing, of course. See, these tumors have two features, okay? These tumors have two features. One is the neuronal feature and second is the endocrine feature. Okay.
Yeah.
So for the neural features, they have a origination with the neuroendocrine cells. And for the endocrine one, they are for the medulla tumor. Okay. That's why they are included in the neuroendocrine ones.
Okay, got it. Thank you.
Dr.
So
Chaudhary, I have a
yeah.
question.
Yes.
So in pheochromocytoma, right, you also have increase in the HVA and VMA. So why is
Yes.
it in pheochromocytoma you get hypertension, but in neuroblastoma you don't
Again,
get
the metabolism is kind of slow in case of this pheochromocytoma. So you will have a more time for the epinephrine and non-epinephrine to work in the body. Okay, but in case of neuroblastoma, you have kind of this high metabolism type thing, So they just don't be there in the for very long time in the bodies. Okay, so they will metabolize very early in the HMA and VMA.
Okay, thanks.
And they will describe these neuroblastoma cells as small round blue cells. Okay, if they do not give you the histology, they will give you a description of the tumor. They will tell you that they have a central lumen, which is kind of eosinophilic, And surrounding that central lumen, there will be these small blue round cells. As you can see, every cell is kind of small, every cell is very much blue, and all of the cells are of same size. And this is a very important thing. For every neuroendocrine tumor, you have a cells which are very much, of same size. Every time you have a very same size of cells. So homogeneous type, you can say. Okay, every cell will be of same size. Every cell will be round. Every cell will be small. Okay, so then comes the pheochromocytoma. Okay, and they are derived from the nucleus cells again. Please remember the germline mutations. It is very important. You can see the pheochromocytoma in the neurofibromatosis type 1. Okay, you can get it with the von Hippel-Lindau disease. You can get it with the RET mutation, which is the MAN2A and the MAN2B syndrome. Okay, so NF1, the BHA, RET mutations for MAN2A, MAN2B syndrome, they are all can cause the pheochromocytoma. You can remember the rule of 10, which is 10% of them are malignant, 10% of them are bilateral, 10% of them can be extrarenal, which means the bladder wall or the other organs. 10% of them can be calcified, okay, and 10% of them will be present in the kids. Okay, so important to remember the rule of 10. Okay. Very important to know. Other things, it would be the markers of this tumor would be, of course, some markers of the neuroendocrine cells would be there. Okay, the synaptophysin, the chromogranin, okay, and the neuron-specific enolase. Right? These all will be in the body. Sorry. So, what are the symptoms of the pheochromocytoma? Of course, the symptoms would be first is the episodic hypertension. Okay, and along with the episodic hypertension, these tumor cells, they also releases the this EPO or the erythropoietin, right? If you guys remember from the von Hippel-Lindau discussion, we have talked. We know that every tumor which is under the von Hippel-Lindau, and what are the three tumors which can be formed by the von Hippel-Lindau this mutation?
Cerebellar hemangioma, retinal tumors, and pheochromocytoma.
Good. Okay, so all of these tumors, they all can secrete the erythropoietin, and that can cause the polycythemia. Okay, and the patient is very important to note that it is not a continuous hypertension. It is not a chronic type hypertension. It is always episodic. It comes in waves, and then it will just go. Okay, and along with the hypertension, because it is kind of a very high hypertension, more than 180 and 120, the crisis would be there. Urgency and emergency would be there. The patient will get a high pressure along with the episodic headaches, along with the episodic palpitations. Okay, patient will get all sort of pallor. Okay, so whenever you encounter a patient, okay, who is having the episodic hypertension, okay, episodic headache, episodic palpitations, okay, all of them can lead to the one diagnosis, which is the pheochromocytoma. And why is this happening? Two things. First is the release of epinephrine and non-epinephrine, okay, and second is this tumor. Second is this the EPO from the cells. Okay, and it is very important to note. Okay, so any doubts so far about the symptoms, about this cause, and about them and about these mutations?
I have one question.
Yes.
Yes, even though we are having polycythemia over here, we can have pallor. Like, isn't that going
Because the
opposite?
blood supply. See, whenever you have a polycythemia, you have a high viscosity. Is that okay?
Yeah, I got it. Yeah.
And whenever you have a high viscosity, the blood flow will be decreased, and because of this decrease in the blood flow, you will have this pallor also.
Okay. Yeah, thank you.
And please remember, the symptoms are always episodic, and this is the most important thing. Okay, step 1 will ask you, they will give you a patient with a pheochromocytoma. Okay, and they will ask you what could be the presenting complaint of this patient. And for the hypertension only, they will give you 2-3 options: the continuous or no hypertension, or the episodic ones. So you need to choose the episodic only. Okay. Now the findings will be, of course, the increased metabolites of the catecholamines, which are the metanephrines, the hypovolemic acid, or the vinyl mandelic acid, HMA, VMA, okay, in the urine and as well as in the plasma. You will always, you will also get the positive neuroendocrine markers, which are the chromogranin, synaptophysin, neuron-specific enolase. These are the three most common type, which you will see in every neuroendocrine tumor. Okay, what is the treatment? We have discussed that already. You need to give the patient alpha blockers first before giving the patient beta blockers. So first give the alpha blockers, then give the patient beta blockers, and then operate on the tumor. But why do you need to give the patient alpha and the beta blockers while doing the surgery? Anyone?
Because when we
To prevent unopposed
Yeah.
alpha activity.
Sorry, I didn't understand. If you can repeat it again, please.
To prevent unopposed
To prevent post,
unopposed
you can please write it in the chat box. Thank you
To
so much.
prevent hypertensive crisis.
I'm not getting a clear voice. I'm sorry about that. Please write in the chat box, whoever is answering. Okay, okay, is it to oppose, to prevent the unopposed alpha? But why you need to give the alpha and the beta blockers also? Why you are giving them? Of course,
because
to prevent. Yeah, what is happening during surgery? Yes.
During surgery, we might press the tumor and there might be an increased release of
Yeah,
epinephrine
exactly.
and norepinephrine.
Yes, exactly. Because during surgery, we can press the tumor.
Yeah.
Okay, somehow, and because of this pressing of the tumor, you can release the catecholamines, and that can stimulate the alpha these receptors, and that's why you need to block the alpha and the beta receptors also. Okay, note this thing. And yeah, and for the alpha blocker, you always give the patient phenoxybenzamin. Does anyone know whether the phenoxybenzamin is irreversible or the reversible type inhibition?
Irreversible.
Irreversible.
And what drug for the reversible one?
Phentolamine and
Phentolamine.
Yes, phentolamine. Yes. Okay, don't forget that. And just like the pheochromocytoma and just like the neuroblastoma, you also have one tumor which is the paraganglioma. And as the name suggests, it is para to the ganglions, which is around the ganglions. Okay, it is a tumor of the sympathetic chain, just like the neuroblastoma. Okay, but it is in the adults, not in the children. Okay, it can arise anywhere in the head, neck, the mediastinum, the abdomen. Okay, versus the pheochromocytoma, which is in the flank region or in the adrenal glands only. Okay, and because you know that adrenal glands can only release the epinephrine, only the adrenal glands can release the epinephrine. No other area in your body, no other neuron can release the this epinephrine. Okay, so in case of paraganglioma, because it is a tumor of sympathetic chain, you can only have a high levels of non-epinephrine. Okay, so you will have a high level of normetanephrine, not the metanephrine. Metanephrine is a metabolite of epinephrine, right? And normetanephrine is a metabolite of norepinephrine. So in case of paraganglioma, you will have a high levels of normetanephrine and the non-epinephrine. Versus in case of pheochromocytoma, you will have a high level of epinephrine and non-epinephrine as well as their metabolites. Okay, but in both pheochromocytoma and in this paraganglioma, you will have a episodic sympathetic hyperactivity, and because of this episodic sympathetic hyperactivity, you will have a episodic hypertension, you will have an episodic headache, you will have an episodic tachycardia. Okay, so everything will be episodic in both the tumors. The only thing that you can differentiate is by the location of the tumor, first thing, and second is the release of epinephrine and the non-epinephrine. Okay, both of the tumors are from the neuronal cells. Okay, they all have the chromogranin synaptophysin positive also. Okay, so do not forget to differentiate between the paraganglioma and the pheochromocytoma. Any doubt? on this page so far?
No, thank you.
Dr. Chaudhary, one question.
Yes.
Why did you give alpha blockade first before beta blockade? Is there a reason? Why can't you give it the other way around?
See, if you give the patient beta blockers first without giving the alpha blockers, what gonna happen? The beta blockers, the beta receptors are actually causing the vasodilation, right? If you block the beta receptors before the alpha ones, then alpha will be hyperstimulated by these uh, by the rays of these catecholamines, right? And if the alpha one are highly stimulated, what's gonna happen? Vasoconstriction. You will end up having a hypertensive emergency and the vasospasms, which can cause ischemia and infarction also, right?
Can you say that one more time?
Can I say that or what?
Can you say that one more time? Sorry.
See, if you give the patient beta blockers first without giving the alpha blocker, what's going to happen? The beta receptors are gone now, okay? And the function of beta receptors in the blood vessels is to cause the vasodilation, and the function of alpha receptors is to cause the vasoconstriction. Okay, so because the catecholamines are releasing in the surgery, okay, and the beta receptors are blocked, so they will only stimulate the alpha receptors, right? And because alpha receptors causing the vasoconstriction and beta 1 causing the vasodilation, you cannot have the vasodilation. You will have an unopposed vasoconstriction throughout the body, right?
Okay.
And that can cause ischemia, infarction, and a very high blood pressure. Okay, that's why.
Okay. Okay. And this is referring to beta 2, right?
Yes, the beta 2.
Okay. Thank you. Thank you so much.
Okay, finally, the multiple endocrine neoplasias. Okay, you have two type of MANs, which is MAN1 and MAN2. MAN1 is code for a tumor suppressing this protein, which is a mannin. Okay, MAN1 is a gene which is coding for a tumor suppressor protein, which is the mannin. It is found on chromosome number 11. You don't need to remember the chromosome number, but you do need to remember the mannin, which is a tumor suppressor one. Okay, what tumors you can have? You can have the tumor of pituitary gland. The most common one is the prolactin. Okay, and second most common is a growth hormone tumor. You can have other tumors also, like the ACTH releasing tumor. Okay, like the thyroid tumor. Sorry, like the TSH releasing tumor. Okay, many other tumors could be there, but the most common ones, almost 80% of times. Okay, and the 50 or 60% times it would be the prolactin tumor. The 20% of times it could be a growth hormone tumors, and rest 20% of time it could be other tumors also. Okay, for the pancreatic tumors, you can have a Zolliger-Ellison syndrome, which is because of the release of gastric the gastrin. Okay, you have a gastrin-raising tumor, which is a Zolliger-Ellison syndrome. You can have an insulin-raising tumor, insulinoma. You can have a glucagonomas also, and you can have a VIP, which is a peptide-raising tumors. Okay, released by the parasympathetic nerves, okay, to cause the relaxation of the smooth muscles, which is the VIPomas. Okay. Then for the parathyroid, you can have a parathyroid adenoma and as well as a hyperplasia. Okay. Parathyroid adenomas and parathyroid hyperplasia, both things can happen in the MAN1. Okay. For the MAN2, it is due to a RET mutation, and RET is the proto-oncogene, okay, which is code for the receptor tyrosine kinase. Okay, which is a tyrosine kinase receptor, the RET. Okay, it is a proto-oncogene. Okay, and whenever it gets mutated, you can have a MAN2A or MAN2B. Okay, for the MAN2A, you have a parathyroid hyperplasia. Please note, it is not a cancer, it is not a tumor, it is or just hyperplasia. Okay, you will have a tumor of thyroid gland, which is the medullary thyroid carcinoma. Okay, which is a neoplasm of the parafollicular C cells. You will also have the pheochromocytoma, which releases a catecholamines. Okay, for the MAN2B, you have a tumors in the thyroid, in the adrenals, okay, the medullary thyroid carcinoma, the pheochromocytoma, along with you can have a mucosal neuromas, which are the neural cell tumors, or I can say the Schwann cells tumor in the mucosas. Okay, very important. Plus, you will also have the Marfanoid body habitus. Okay, which is same as that of having a Marfan syndrome. You will have a symptoms or the habitus of the body is similar to the Marfan's one. Okay, a long, tall individual. Okay, a very long hands, long feet, flat feet. Okay, the tapering fingers, arachnodactyly would be there, long fingers with tapering ends. Okay, the presentation will be similar to that of uh, the Marfan syndrome, right? But along with that, the patient will have some bumps on the mucosal surfaces like the tongues. As you can see, these are the mucosal neuromas. Plus, the patient will also have the pheochromocytoma and the medullary thyroid carcinoma. So it will so the mucosal neuromas will present as the flesh-colored nodules on the mucosa. If they do not give you the picture of the patient, they will describe these tumors as the flesh-colored nodules on the mucosa. Okay. Okay. So yeah, that would be all. So any doubt on the multiple endocrine neoplasias? Once. Any doubt?
I have one question.
Yes.
What does VIPoma present with?
It will present with the diarrhea. The secretions will be increased. You will get a secretory type diarrhea. Okay. Very importantly, you will get the hypokalemia. Okay. And you will get a dehydration. Mostly diarrhea will be the prominent symptom, and because it is a secretory type of diarrhea, you will get a diarrhea even in the night while sleeping. Okay. You don't need to eat any food. You don't need to eat any toxin. It's just a secretory diarrhea, and that's why whenever even in the empty stomach you will get a diarrhea, okay, while sleeping also. So these are the symptoms for the VIPomas.
Okay, this will be covered in GIT.
Yes, this will be covered in GIT. Don't worry about that. You will encounter that later again.
Okay, and do we need to remember those angiofibromas, collagenoma, and meningioma in MEN1?
Yeah, you can remember, but I have never encountered any question on these three, so I just redline them. You can remember them, no doubt.
Okay.
But I've never encountered any question with these tumors, so I just left them. Not an important one, okay. And yeah, how does a patient with the MEN1 can present you? Of course, they won't give you the history of the patient like that they are having the pathoid adenoma or they're having this pituitary adenoma or tell me what type of MEN syndrome it is. No, they will give you the presentation of the patient. Okay. For the pathoid adenoma, they will give you the renal stones. Okay. They will give you the constipation history. They will give you the increased urination history because of the hypercalcemia, right? For the pituitary tumors, they can give you a history of headache, just a headache and nothing else. Okay. For the pancreatic tumors, which is a solicular ulcer syndrome, most commonly they will give you a history of ulcers. So whenever you encounter a patient with a GI ulcer, with a stone, with the hypercalcemia symptoms, with a headache, that means it is a MEN1 syndrome. They can ask you, they will, after giving 2 of the 3 tumors history, okay, symptoms which are belonging to 2 of the 3 tumors, they can ask you for what other tumor, okay, we need to test the patient, or what could be the next step in the management of the patient. The management would be to test the patient for other tumors also. Okay, if you're having a GI ulcer along with the stone, okay, that means the patient is having a Zolliger Ellison syndrome along with the parathyroid adenoma. Then you need to test them for the pituitary tumors also. You need to check for the prolactin levels. You need to check for the brain MRI, right? That's how a question could be presented to you, and that's how you need to encounter it. Is that okay?
Yeah.
Similar thing for the MEN2A, similar thing for the MEN2B. They will give you the history of 2 of the 3 tumors, and they will ask you what would be the next step in the management of the patient. And that would be to test the patient for other tumors also. Then let's discuss about the pancreatic islet cell tumors, which are the tumor of beta cells and the alpha cells and the delta cells. For a tumor of beta cells, they will release the insulin too much, and so that you can have a hypoglycemia. Okay, and does anyone know in the brain in what center of the brain I have a high metabolic demand, which means in the scenario of hypoglycemia, what would be the first center in the brain that would be damaged?
Same cells that have high oxygen demand, like Purkinje cells.
Yes.
Hippocampus.
Yeah, exactly.
Cells.
Step 1 can ask you this thing also. Whenever you have a hypoglycemic episode, the first cell or the first center in the brain to be damaged are belong to the hippocampal cells or the Purkinje cells. Okay, it's very important to note that thing. Okay, so what is the symptoms of the insulinoma? You will have a low blood glucose, and because of the hypoglycemia, you will have an activation of the sympathetic system. Okay, so we'll get the sympathetic symptoms like the palpitation, the diaphoresis, tinglings, tremors, anxiety, hunger, sweating. Okay, which is a diaphoresis, of course. Okay, so these are symptoms of hypoglycemia which you will get along with the insulinoma. Okay, you will get the resolution of the symptoms after after the blood glucose levels will be normal. So symptoms would be just for the hypoglycemia only. Okay, and when you check for the C-peptide level, you will have a raised C-peptide level because it is a endogenous insulin production. Versus if you take the exogenous insulin, then you have a normal C-peptide levels. Okay, very important. And of course, almost 10% of the cases are belong to the MEN1 syndrome. And what is the treatment? Treatment would be to remove it surgically. Okay, so low blood glucose. Along with the low blood glucose, you will have the symptoms for the low blood glucose. Okay, and the symptoms would be a kind of normalized or the resolves after the normalization of blood glucose level. Okay, C-peptide level must be high to ensure that you are having a high insulin production endogenously. Okay, because step 1 will ask you this fact. Okay, the patient is having a hypoglycemia. What would be the next thing you will check in the patient? That would be the C-peptide level to make sure whether it is a exogenous insulin use or whether it is a endogenous insulin use. Okay, because sometimes you have a malingering this patient. Okay, so for the malingering ones, you need to check for the C-peptide levels. Okay, any doubt on the insulinoma?
No, thank you.
Okay, then a very important one is the glucagonoma. It is a very most confusing because symptoms are kind of very much vague, which can resemble other tumors or other symptoms or other conditions also. Okay, so you're you need to be very much careful while diagnosing the patient for the glucagonoma. Okay, so first thing would be in case of glucagonoma, because you're having a high glucagon levels. Okay, so first thing would be the diabetes in the patient. Okay, so whenever the step 1 give you a patient with a glucagonoma, they will always tell you that patient is having a recent diagnosis of the diabetes within 6 months or 7 months. Okay, and this is a very important thing. Whenever a patient has a new diagnosis of the diabetes within 5 or 6 months, and after these after diagnosis of this diabetes, now patient is presenting you with other symptoms also like the dermatitis, which is a necrolytic type of rash. Okay, it is a necrosis type rash in the skin, and it is a migratory rash. Very important. Sometimes it would be on your hand, sometimes it would be on your face, sometimes on the legs, sometimes on the thorax, sometimes on the abdomen. So it is a necrolytic type of migratory erythema. So along with the diabetes, if the patient is having having this dermatitis, okay, that means it is a glucagonoma. And if you guys remember, the necrosis, this necrolytic type of rash is also seen in the zinc deficiency. Remember the dermatitis of the zinc?
Yeah, acrodermatitis enteropathica.
Yeah, where you have the dermatitis along with the diarrhea also. All right, so symptoms can mimic the zinc deficiency. Okay, but in zinc deficiency, you always have the anosmia, you will have the hypogonadism, you will have the poor wound healing. If these things are not given, that means it is a glucagonoma. In the glucagonoma, you will have a recent diagnosis of the diabetes, you will have a dermatitis, you will have a diarrhea, you will have a weight loss also. Okay, so whenever you get this kind of presentation, just diagnose the patient for the glucagonoma. Okay, this is very important. So yeah. So whenever you encounter a patient with any, if you don't want to remember dermatitis, just remember any rash on the body, along with the diabetes and diarrhea. That means a glucagonoma. Okay, because sometimes I describe this rash as very complex thing. They will describe you like a painful pruritic rash, okay, which is on the face, groin, or the extremities. Okay, then this rash will form the papules and then the ulcers, okay, which is a brown or bronze color. So it is a kind of very complicated presentation for the for the rash, right? So you can just remember it by the rash, diabetes, and diarrhea. Okay, whenever you get these 3 symptoms, that means it is a glucagonoma. They can also ask you what other symptoms could be present, which would be the deep vein thrombosis and the weight loss. And treatment would be to give the patient octreotide, because you guys already know the somatostatin is an inhibitor of the glucagon. Okay, and the second would be to remove it surgically. Okay. Any doubt on the glucagonoma?
Why do we have diarrhea? Is it because of hyperglycemia, osmotic diarrhea?
Yes, of course. One is osmotic diarrhea, and second is because of the glucagon itself. It increased cyclic AMP levels. Remember the cyclic AMP thing, the glucagon.
Yeah, it increases.
So by increasing the cyclic AMP level in the GIT, it can also cause the increased secretion of the the sodium and the chloride, right? So you can also get the diarrhea because of it. Okay.
Thank you.
Then comes the somatostatinoma, in which you have a high somatostatin levels, and high somatostatin levels can suppress both the insulin as well as the glucagon, right? But the insulin suppression is much more than the glucagon, and that's why in case of somatostatinoma, you will have the diabetes. Okay. Although the somatostatin suppresses both the glucagon as well as the insulin, but the insulin suppression is more than the glucagon, and that's why you will have a diabetes in the patient. Okay, you will also have the steatorrhea. Why steatorrhea? Anyone can try. Why steatorrhea? Why the fat loss?
Because the pancreas isn't giving you the proper digestive enzymes.
Okay, and second thing is somatostatin also inhibit the pancreatic enzyme secretion.
Okay.
Okay, that's why you will get the steatorrhea. You will get the gallstones. Why gallstones?
Because of the police invasion.
Because please speak one by one.
Why? Is not going to be produced. Cholecystokinin inhibition.
Yeah, exactly.
The gallbladder will not contract.
Yes, exactly.
Because somatostatin is going to inhibit secretion of food.
Yeah, somatostatin inhibits the cholecystokinin. So cholecystokinin won't be there to cause the contraction of the gallbladder. So you will get the gallstones. You will also get the achlorhydria, which means you will have a no HCl, because you know whenever the somatostatin is there, it will suppress the HCl production in the stomach, right? So achlorhydria, gallstones, steatorrhea, and the glucose intolerance. It would be the symptoms of your somatostatinoma. It is a tumor of delta cells. Okay, it will form, and it will be the overproduction of the somatostatins. Treatment, of course, the surgical resection, and you can and you can also give a long-acting drugs like the octreotide for the symptoms control. Long-acting drugs must be used. Okay.
Wouldn't they worsen the symptom? Like somatostatin itself is causing symptom.
I thought the same, but when I read the article, I realized that octreotide is actually useful in the somatostatinoma. Just for the symptoms, okay, just for the symptoms control. The surgical resection is the ultimate thing that you will do for the patient, but for the symptoms, for some time, you can give the patient octreotide also. I've searched on the Google, and it is a therapy that is being used nowadays. Okay, so yeah, you need to remember this octreotide.
Okay, thank you.
I know it is kind of very much confusing that giving the somatostatin in the somatostatinoma, but you know we use that. It is kind of very much confusing. Okay, so for the symptoms of somatostatinoma, you can remember them by like inhibition of the insulin, inhibition of the glucagon, inhibition of the growth hormone, inhibition of the gastrin, and inhibition of the cholecystokinin. Okay, so all of these symptoms are because of inhibition of these hormones. Okay.
Dr. Chaudhary, quick question.
Yes.
Why can't you give octreotide in insulinoma, because it can also suppress the insulin, right?
Why we are giving octreotide in the somatostatinoma?
No. Why can't you give octreotide in insulinoma?
Well, I really don't know the treatment. It is a step 2 thing. I just showing what is written. I just remember what is written. So it is a step 2 thing generally, right?
Okay, never mind. Thank you.
Thank you so much. It's all about the efficacy, I think. It may be not very much efficacious in case of insulinoma, so you are not giving. Okay, so might be the case. Okay, now comes the carcinoid tumors, which are another example of neuroendocrine tumors. Okay, the carcinoid tumors are mainly from the lungs and from the intestine. Okay, these are very rare tumors. Okay, and and the symptoms of the carcinoid tumor does not occur if it is remaining, if it is limited to the GI tract only. Very important. Okay. If the tumor is limited to the GI tract, okay, then the symptoms of this carcinoma tumor or this kind of the carcinoma tumor won't be occur, right? Why? Because your liver has the enzyme that can metabolize the serotonin. Please remember, all of the symptoms of the carcinoid syndrome are because of the serotonin release. And because your liver have the enzyme which can metabolize the serotonin, okay, it won't be causing any symptoms. Symptoms will only occur whenever the tumor metastasizes to the liver, okay, and bypassing this enzyme now. So whenever you get the symptoms of the carcinoid syndrome, that means the tumor has already metastasized. Very important. If you are having symptoms, that means the tumor is already metastasized. Okay. So just like any other tumor, you will have the just like any other neuroendocrine tumor, you will have the synaptophysin, you will have the chromogranin, you will have the neuron-specific enolase positive, you will have a prominent rosettes in it. Okay, as you can see, all the circular islands, okay, surrounded by the cells, and these cells have some kind of the granular appearance of the cytoplasm. If you can see, all of these cells have a granular appearance of the cytoplasm, right? As you can see in these cells, okay, and all of the cells are bluish. So cells making a circular islands, okay, and they are having a granular appearance of the cytoplasm. These are the that's how the Stepan will describe you these carcinoma tumor cells, okay, or the prominent rosettes. Okay, so these tumors release the 5-HT, which is the serotonin, okay, and because of the serotonin release, it can cause the diarrhea, it can cause a bronchoconstriction, it can cause a vasoconstriction also. You can have a diarrhea, wheezing, high BP, okay, and it will cause the fibrosis of the complete right side of the heart. It will cause the fibrosis of the complete right side of the heart. Okay, so you will have an endocardial thickening, you will have the fibrosis, you will have a tricuspid and the pulmonary valve involvement. In the tricuspid valve, you can have a regurgitation. In the pulmonary valve, you can have a pulmonic stenosis. Okay, and a right-sided heart failure because of the fibrosis. Okay, so a right-sided heart failure, fibrosis, which can cause a regurgitation, stenosis. Okay, you will also have a niacin deficiency. Why?
Because tryptophan is now used in synthesis of serotonin and not much in niacin synthesis.
Yes, exactly. That's why we will have a pellagra also. And what are the symptoms of the pellagra?
Dermatitis, diarrhea, dementia, hallucinations, and death.
Exactly. Yeah. Yes, exactly. Okay. So, as you know that your liver also have the enzyme which can metabolize the serotonin. So they will release the metabolite which is the 5-HIAA. Remember this metabolite, very important. You will always measure the levels of this 5-HIAA to diagnose the patient for the carcinoid syndrome because of this metabolite, and it is done by the liver. Okay, whenever serotonin passes through the liver, it will undergo the first pass metabolism. Okay, and it will release the 5-HIAA, which could be measured in the urine as well as in the blood for the elevated levels, and by elevated levels you can diagnose the patient for the carcinoid syndrome. So step 1 will ask you and at what levels you will measure for the carcinoid syndrome. This would be the 5-HIAA. Okay, enzyme is also present in the lungs. Okay, and that's why whenever the serotonin passes through the lungs after after the right side of the heart, it will be metabolized, so patient won't get any left heart symptom. Okay, symptoms are only limited to the right heart, but if the patient if the patient is having a carcinoid for the lung, then in that scenario left heart will also be included. Okay, it will be involved also. So whenever the patient has a right and a left-sided heart failure both, that means it is a the carcinoid of the lung. If the patient is just having a right-sided heart symptoms, that means it is a carcinoid of the GI tract. Okay, a very important differentiation. You can do the CT and MRI also for the tumor location. Okay, and all of the tumors, they will reach the liver via what vessels?
Portal vein.
Portal veins, very important. Okay, step 1 will also ask you this, that what could be the most common way or the path for the metastasis of this tumor, it would be the portal vein. Okay. So for the treatment, we will give the patient somatostatin analogs, okay, for the symptoms control, of course. And second thing is be the surgical resection of the tumor. 1/3 of the tumors will be metastasized. 1/3 will be the secondary, with the secondary malignancy also. Okay, and 1/3 are multiple locations. Okay, very important. So, any doubt on this tumor so far? And yeah,
Thank you.
remember these symptoms also. Flushing, very important. See, for the clinical manifestations, all of them are due to the serotonin release, which can cause the skin. In the skin, it will cause a flushing, telangiectasias. In the GIT, it will cause a diarrhea, abdominal pain. In the respiratory, it will cause a shortness of the breath. In the cardiac, it will be seen as the valve plaques. So whenever you encounter a patient having a flushing and the diarrhea, okay, having a flushing and the diarrhea, along with the lung symptoms, okay, or with the GI symptoms, okay, like the abdominal pain, that means it is always the carcinoid syndrome, because flushing and diarrhea and wheezing can also happen in case of the histamine release also. Okay, but along with the flushing, diarrhea and wheezing, if you're having any kind of mass in your body, okay, that means 100% times it could be the carcinoid syndrome. Okay, so don't forget, a flushing, diarrhea, wheezing along with any mass in the body, that means a carcinoid syndrome. Okay, then comes the Zolliger-Ellison syndrome, which is a tumor that releases a gastrin. Okay, it releases a gastrin that causes a very high HCl production, okay, in the stomach, and this high HCl will be enter your duodenum, okay, and in the duodenum it can cause the ulcers. And please remember the location of the ulcer. It would be the distal duodenum and the jejunum. Okay, the normal ulcers, the benign ulcers that you find in the duodenum, they're always in the proximal 1/3 of the duodenum. Remember? Yes.
Yeah.
But in case of Zolliger-Ellison syndrome, you always have a distal, you always have the ulcers in the distal 2/3 of the duodenum or the jejunum. Okay, so whenever you encounter a patient who is having the ulcers in the distal duodenum, it is always 100% of time gonna be a case of your Zolliger-Ellison syndrome in the step 1. Okay, and whenever you have a proximal ulcers, that means it is a normal ulcer because of H. pylori. Okay. So because you have a duodenum and the jejunum ulcers, it will present as the abdominal pain. It will present as a heartburn. Okay, it will be just like the peptic ulcer disease. You will have the abdominal pain. You will have the heartburn. Okay, you will have the diarrhea because of the malabsorption. Okay, and sometimes the ulcers can also cause the bleeding. Okay, because of the bleeding, you can have a GI hemorrhage. You can have a bloody diarrhea. Okay, and you can also have a bloody vomiting. Okay, and they will describe this vomiting as a coffee ground emesis, because the hemostatin will be mixed with the vomiting. It will make the vomiting very brown. Okay, that's why the coffee brown emesis, they will describe it generally. Okay, why these symptoms are occurring? Because of high gastrin level that was leading to the high HCl level. Okay, now generally what happens, if you give the patient a secretin, okay, if you give the patient secretin, then it will inhibit the gastrin production. Very important to note. Okay, if you give the patient secretin, then this gastrin production will be inhibited. But in case of Zolliger-Ellison syndrome, okay, even if you give the patient secretin, the gastrin levels are remaining elevated, or they even become more elevated after giving the patient secretin, or you can say a paradoxical increase in the level of gastrin after giving the patient secretin is a very highly characteristic feature of the Zolliger-Ellison syndrome. So can anyone tell me why is that the case? Why giving the secretin I'm having a high level of this gastrin? When the
Because alkaline pH stimulates gastrin secretion.
No, any other cause? I mean, this could be, but not the major one. Does anyone know the location of secretion of this gastrin?
It is
G
secreted
cells.
by G cells at the antrum.
In the antrum, right?
No.
And in any other location where, see, this Zolliger-Ellison syndrome is a tumor of which organ? Stomach?
No, it's pancreas.
pancreas. So in this case, this gastrin will be releasing from the pancreas, not from the stomach. Okay, secretin can only inhibit the gastrin which is releasing by the stomach. Okay, while in case of pancreas, secretin increases the secretions of the pancreas. Is that okay?
Yeah.
Secretin causes increased secretion from the pancreas, and because the ZD syndrome is a tumor from the of the pancreas, right? So whenever you give the patient secretin, instead of inhibiting the gastrin levels, it will activate them. It will increase the levels. Okay, that's why.
Like starts autocrine system, like it is
Yes.
secreting.
Yes, exactly.
Or autocrine loop, isn't it?
Yeah, something like that. You can say it. Okay.
Okay.
But just remember one fact. Okay, in case of a normal individual, because this gastrin will be releasing by the antrum, right? So this secretin will inhibit that part. But in case of pancreas, this secretin actually stimulates the pancreatic secretions. So it will cause more a release of the gastrin from the pancreas if you give the patient secretin. And this is a positive secretin stimulating test. A positive secretin stimulation test. And it is also associated with the Mann-1 syndrome. Okay, very important. And yeah, because this gastrin, it also stimulates your GI mucosa and causes the proliferation of the parietal cells. So whenever you do the endoscopy of your stomach, you can see a increased gastric folds or the gastric ragae. Okay, and the thickening of the gastric wall will also be increased. Okay, it is also very important. When you do the endoscopy, what you will see is the visible enlargement of the gastric folds. Why? Because the gastrin, it also stimulates the parietal cells. It causes the proliferation of the parietal cells, right? And because of the proliferation of the parietal cells, you can have a increase in the gastric folds. Another important thing. So a parietal cell hyperplasia, which is releasing the HCl, and for that you're having every symptom of the SAD syndrome. Is that okay for everyone? Any doubt so far?
No, thank you.
Okay,
Why
then
was
yeah.
the parietal cell hyperplasia? That's going to be in this. Why is that important?
Parietal cell
that's
hyperplasia.
Never mind. Never mind. I'm sorry.
Okay.
I'm good. Thank you.
Okay, no problem. Okay, now then comes the diabetes mellitus therapy. Okay, for the type 1 diabetes mellitus, you guys already know you need to do the insulin replacement, because the major cause of the type 1 diabetes mellitus is because of low level of insulin, right? For the type 2 diabetes mellitus, it is the resistance against the insulin. So you need to give the patient those therapies, okay, which can decrease the resistance of the insulin. And the most common one is the metformin. So metformin is the first line therapy for the diabetes. Okay, you can also give the patient other therapies, other non-insulin injectables like the thiazolidinediones, okay, like the GLP analogs and other drugs also, right? You can also do the insulin replacement. You will give the high dose of insulin so that the resistance could be overcome. Okay, and weight loss is a very helpful thing in the type 2 diabetes mellitus, because you know that high level of triglycerides or the visceral fat is actually causing the insulin resistance. So if you do the weight loss, it is extremely helpful in treating the type 2 diabetes mellitus. Okay, and you guys also know, while doing the exercise, you're actually causing a release of calcium that can stimulate the translocation of the GLUT4 receptors on the surface of the cell, right? And they can promote the hypoglycemia, right? So two benefits of doing exercise. One is a decrease in the fat, and second is the activation of the GLUT4 receptors for the translocation, right? So and because of these two things, you can actually lower down the blood glucose levels. Okay. For the gestational diabetes mellitus, you will do the nutrition therapy, okay, and exercise first. If the exercise and the nutritional changes fail to do that, you will give the patient regular insulin. Very important. Okay, and yeah, that's all. Okay, now let's discuss the insulin preparations. Okay, and all of them, they are given subcutaneously. Okay, all of the insulin preparations, they are all given subcutaneously. First thing, okay. Then you need to remember the time of acting of these agents. Okay, the rapid acting ones, they includes a lispro, aspart, and the glulicin. Very important. Okay, the rapid acting ones are the lispro, aspart, and the glulicins. Okay, and because they are rapid acting, okay, the level will be rise very much high in a short duration time, and they will fall very rapidly, so they can mimic the postprandial insulin release. Okay, all of these agents, they can mimic the postprandial insulin release. Okay, first thing. Second ones are the short acting ones, which have a peak for like 2 to 3 hours. Okay, and it is the insulin regular. Okay, it is the insulin regular, and you use this insulin regular for the diabetic ketoacidosis. Very important. You will use the regular insulin, as you can see also. The regular ones are used for the diabetic ketoacidosis. Okay, so regular one for the diabetic ketoacidosis. Why? Because in case of diabetic ketoacidosis, you will give the regular insulin by the IV route, not by the subcutaneous route, but by the IV route. And giving the regular insulin by the IV route, it can mimic the lispro, aspart, and glulicin function. Okay. See, if you look on these curves, this is a regular subcutaneous curve for the regular insulin. Okay. If you give the regular insulin by the IV route, it will mimic this curve, the curve for lispro, aspart, and glulicin. Okay. It will be very rapid action. Okay. And you can easily control the level of this drug. Okay. And because you can control the level of this drug very easily, that's why it is a very preferred drug for the diabetic ketoacidosis. Okay. Then comes the intermediate acting ones, which are the NPH. Okay, they have a peak, and they can, and their effect would disappear for like after 14 hours. Okay, then comes the very long acting ones. Okay, which do not have any real peak. Okay, so these are the datamere and the glargine. Very important, the datamere and the glargine, and you use these agents to mimic the basal insulin secretion, 24-hour insulin secretion. To mimic the 24-hour insulin secretion by the beta cells, you will give the patient these long-acting ones. So if the step one asks you by these therapies how you can mimic a normal, uh, 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 you know, a normal insulin release. Okay, so that would be to give the patient the rapid-acting ones, the lispro, aspart, the glucin, just before the food or just before the meal. Okay, and you will take a one shot daily for the long-acting ones to mimic the basal insulin release. Okay, because that's how this insulin will be functioning in your body, right? When you take no food, the insulin level will be somewhere normal. Okay, a basal level will be there, and whenever you eat a meal, the insulin level must be rise just after the meal, right? And this could be made by the lispro, aspart, and the glucin. Okay, so mimic the regular insulin release. You will give the patient the rapid acting ones and along with the long acting ones. The rapid acting ones, they should be taken just before the meal, and the long acting ones, it would be taken once a day, daily, to mimic the normal insulin release. Okay, so any doubts so far?
Could you please explain once more the reason why we give regular insulin in diabetic ketoacidosis?
See, the regular insulin, you need to give it the IV route. Normally, you give all these agents by the subcutaneous route, and this graph that you're seeing here, okay, it is the graph of all these agents when you're giving them subcutaneously. Okay, but in case of diabetic ketoacidosis, you give the regular insulin IV route, and by giving it the IV route, you can mimic them like the lispro, aspart, and the glucin, this curve. Okay, and by giving this regular insulin by IV route, okay, you can easily control the level of this drug. Okay, it is very easy for the physician to control the level of these drugs, this regular insulin. That's why we use it.
Okay, I got it. Yeah, thank you.
And once this when this the decay will be normal, okay, you will shift the patient from this IV regular insulin to the subcutaneous regular insulin after that, once the patient is treated. Okay, and just before the discharge, you will switch the patient to the lispro, aspart, glucin, and one glargine. Okay.
Okay, yeah. Okay, thank you.
Okay, so what are the adverse effects? It could be the hypoglycemia. If the patient takes a dose of this lispro, aspart, glucin, but they forget to take the meal, the patient can have a hypoglycemia. You will have a lipodystrophy, which is kind of lipid changes in the body. Okay, and it is a weight gain also. Can anyone tell me why weight gain?
Insulin stimulates fat synthesis in the adipose tissue.
Yeah, it is one thing. And any other cause? Any behaviorological cause? Behavior cause for the weight gain?
Patients are thinking that we are we are taking insulin, so they eat more
Yeah,
kind
exactly.
of.
It is a very important thing. All the patients who are taking the insulin, okay, they think that if they take the insulin, then they can get the hypoglycemic episode. They eat more, and this why and it can promote the weight gain also. Okay, so please remember this fact. Okay, so any more doubt?
No, thank you.
Okay, just give me a second.
I have a question.
Yes.
Do we use insulin in patients of CKD and liver disorders?
Can I use the insulin for the kidney disorders? Well, it depends upon the resistance, because you know that in case of insulin resistance, sorry, in case of a chronic, in case of a CKD, you are having an insulin resistance because of of all these toxins, right? So the first important thing is to do the dialysis of the patient, right? Before giving an insulin therapy. If you do the dialysis, the resistance will be automatically inhibited, right?
Yeah.
So the first thing you will do is to do the patient dialysis and then check for the insulin levels. You will promote the exercise first. Only if the levels are full, then you can give the patient metformins. Okay, because this is a preferred one in case of insulin resistance, right? The metformin. So it depends upon the resistance again, because we need to treat the cause first before treating the symptoms, right? So dialysis will be the ultimate treatment for any patient who is having a this insulin resistance because of the CKD. Okay, and along with this, you can promote the the exercise in the patient. If these therapies fail, then you can give the patient metformin. Okay, yeah, that would be all.
Okay.
Okay.
Dr. Chaudhary, I have a quick question.
Yes.
Earlier you were explaining the in Zollinger-Ellison syndrome, right? The secretion of the secretin from the stomach versus the pancreas and all that. Do you mind just repeating that? I didn't understand.
See, normally what happens, the gastrin is releasing by the antrum of the stomach. Okay, and does anyone remember what cell releases the gastrin?
G cells.
Okay, the G cells will release the gastrin from the antrum, right? And when you give the patient secretin actually inhibits the G cell. Okay, so whenever you give the patient secretin, it will inhibit the gastrin release. But this ZE syndrome, it is because of a tumor in the pancreas, and it is the pancreas now which is releasing the gastrin. Okay, and secretin actually stimulate the pancreatic secretions. Okay, so whenever you give the secretin in case of a ZE syndrome, it actually stimulates the pancreas to release more gastrin. Okay, instead of inhibiting it. So this is a test you will do for the ZE syndrome.
Okay, so secretin actually stimulates increase of gastrin from the pancreas, but at the same time, it inhibits the
gastrin by the stomach.
Oh, okay, okay. Thank you.
Yes. So the patient with the insulin therapy, they often eat more due to the fear of hypoglycemia, and that's why weight gain will be happening. So the step one will also ask you that what therapies you can give patient to for this weight gain. This would be the counseling of the patient. I've encountered a question on this fact. Okay, and the answer was the counseling of the patient is very important for the weight gain. Okay. And for the patients who are having a longer standing diabetes, we have discussed that fact. If you're having a very long standing diabetes, then in that case, the alpha cells will be inhibited too, right? And as a result, the glucagon will be lost and the patient can get a risk of hypoglycemia if they keep on taking the drugs. Okay, sometimes it happens. Okay. Then comes the therapies for the type 2 diabetes mellitus. Okay, the first one is the metformin. Okay, metformin actually upregulates the enzyme, which is the AMPK, okay, or the AMP activating protein kinase, okay, which inhibits the lipogenesis. Very important. It is given in the U world, okay. The metformin upregulate the enzyme, which is known as the AMP activating protein kinase, okay, that inhibits the lipogenesis, okay. And secondly, it inhibits an enzyme which is the GPD that converts the glycerol to the glucose. Okay, so you inhibit this enzyme, you're actually inhibiting the conversion of glycerol to the glucose. So that's how this drug, the metformin, can inhibit the gluconeogenesis and inhibit the lipogenesis. Okay, it also promotes the sensitivity of the insulin, so it increases the insulin sensitivity. Okay, it promotes the peripheral glucose uptake. Okay, and it also inhibit the action of the glucagon, okay, which is to inhibit the glycolysis. So three things: one is the inhibition of gluconeogenesis, second is the inhibition of the glycolysis, sorry the glycogenolysis. Third thing is to promote the glycolysis, and fourth thing is the peripheral glucose uptake, and the fifth one is the lipogenesis. These five things are done by the metformin. Okay, side effects are very important. The most common one includes a GI upset. Most of the patients who take the metformin, they stop the therapy because of the nausea, vomiting, and diarrhea. Okay, in the patients who are having a renal insufficiency, this metformin can cause a lactic acidosis, and that's why you always need to do the renal function test first before prescribing the patient metformin. It is a very important thing. The renal function test must be done before prescribing the patient metformin. For that, you will check the creatinine level for the patient. Okay, vitamin B12 deficiency happens after a very prolonged use of the metformin. Okay, weight loss is happened and it is often desired. Okay, and the metformin, it do not causes the hypoglycemia because it do not causes the insulin release. Okay, metformin, they do not causes the release of insulin. Okay, they're just promoting the sensitivity of the insulin. They're inhibiting the gluconeogenesis. They're promoting glycolysis. They're inhibiting lipogenesis. Okay, but they do not causes the hypoglycemia because they do not cause the insulin release. So no risk of the hypoglycemia. Okay. Any doubt on metformin?
You have written inhibition of complex of ETS.
Yes.
What is that?
Yeah, metformin actually inhibits some of the complexes of the ETS also to decrease the this energy so that more glucose could be used by the cells again for the glycolysis. Okay, and that is a mechanism by which it can also cause a lactic acidosis in the renal insufficiency. Okay, this is a mechanism.
Yeah, basically it inhibits oxidative phosphorylation.
Yeah,
and
exactly.
cell is
And
turned
it,
into
yeah,
anaerobic. Yeah.
and it generally happens whenever the renal
Insufficiency is
insufficiency is
present.
there. Yes, exactly. Don't forget that. Then comes the glitazones or the thiazolidinediones. Okay, these are the rosiglitazone and the pioglitazone. They activate the PPAR gamma. Remember the PPAR alpha where we have studied them? The the PPAR alpha activators. Does anyone remember?
Hyperlipidemia.
Hyperlipidemia and what drugs?
Was it ezetimibe?
No. Fibrates, gemfibrocil, right? Fenofibrate. They activate the PPAR alpha, and the glitazones, they activate the PPAR gamma. And by activating the PPAR gamma, they actually promotes the insulin sensitivity. Okay, they will activate the enzyme which is known as the adiponectin, a protein which is known as the adiponectin, and this adiponectin, okay, it causes the differentiation of the adipocytes, and by the differentiation of the adipocytes, it can promote the insulin response. It can promote the insulin sensitivity. So by activating the PPAR gamma, it will cause a differentiation or the maturation of the adipocytes. And by the maturation of the adipocytes, it causes the sensitivity of the insulin. It increases the sensitivity of the insulin, right? Adiponectin. Very important. It also inhibits the TNF alpha, and you guys remember that TNF alpha causes the resistance against the insulin. Does anyone remember how?
It
How
causes
TNF alpha? By the
serine
by the serine phosphorylation.
phosphorylation.
Okay. So the glitazones, they also inhibit the TNF alpha, and they also inhibit the leptin, and leptin promotes the weight loss. So a risk factor of this patient, a side effect of the patient is the weight gain, as you can see. Okay, side effect will be the weight gain. They will cause the fluid overload in your body, and by the fluid overload, it can cause the edema and the heart failure. Okay, they also have a risk of myocardial infarction, and death generally occur because of the cardiovascular complications. Okay, so the side effects will be the weight gain and the fluid overload. Or you can just think about the fluid overload. Whenever you have a high fluid volume, you can have a weight. Okay, you can have a weight gain, you can have a heart failure, you can have a edema. Okay, so for the glitazones, just think about the volume overload as a side effect. Okay, any doubt on them? Any doubt?
I have a question from metformin. Like,
Yes.
how is lactic acidosis associated with renal failure?
Because they inhibit the complex of ATS, we have discussed, I think.
Okay.
So
All
they're
right. Okay.
so they're inhibiting the oxidative phosphorylation, right? So the non-oxidative way will be activated, which is a lactic acidosis formation, right? Lactic acid way.
Okay. Okay. Thank you.
Okay, then comes a drug which increases the insulin secretions. Okay, and these are the sulfonylureas, first generation and the second generation. First generation are not in much use now. Okay, these are the chlorpropamide. Okay, which causes the disulfiram-like reaction. Okay, and does anyone remember the drug disulfiram? What does it inhibit?
Aldehyde dehydrogenase.
Conversion to alcohol.
Yes, it will inhibit the conversion of aldehyde to acid, right? So aldehyde will be increased, and that can cause a worsening symptoms of the alcoholism, right? So these drugs can cause the disulfiram-like reaction, and now they are rarely used. Second generation ones are commonly used drugs. Okay, these are the glipizide and the glyburide. Okay, they inhibit the potassium channels, and you guys know that by inhibiting the potassium channels, I can I can cause the depolarization of the cell so that the calcium influx can happen and insulin will be released. So they're causing the endogenous increase in the insulin. Okay, so whenever you encounter a patient who is having a hypoglycemia and an increase in the and an increase in the C-peptide levels, that means two things could be there. One is the insulinoma, and second thing is the sulfonylurea use. Because in both scenarios, you're having a high endogenous insulin, means high C-peptide levels. So they can cause the hypoglycemia because they are releasing the insulin. They can cause the hypoglycemia, and of course the weight gain also. Okay, and they all agents are the long-acting one agents. They are long-acting ones, so they can cause a prolonged hypoglycemia for like 7 or 8 hours. So if you encounter a patient who is having a hypoglycemia for 7 to 8 hours, okay, so it would be a patient in which you give which come to emergency department with the uh, with the symptoms of the hypoglycemia. Okay, you give the patient glucagon, or you give the patient the glucose, IV glucose. Okay, and then after some time, after stopping the therapy for this hypoglycemia, the patient again developed the hypoglycemia within the hospital. Okay, when you stop the glucose infusion, the patient again developed the hypoglycemia within the hospital. Okay, and it happens for like 7 to 8 hours. That means it is a case of glipizide and glyburide. If the patient has taken these drugs, the glenide ones, the repaglinide and the netaglinide, okay, these are the short-acting ones. Only one dose of the glucose is sufficient to recover from the hypoglycemia. Okay, so step one, after step one can give you a history of the patient who is having a high C-peptide level. Okay, you have admitted the patient, you have given them the glucose infusions. Okay, and after some time, after stopping the glucose infusion, the patient again developed the hypoglycemia. That means he has taken the long-acting ones. If after giving the patient glucose infusion, the patient will be normal, that means he has taken the short-acting ones. So step one will give you both the options. After giving you a scenario, they will give you both the options. You need to choose the one based on the time of action, okay, based on the duration of the action. Okay, any doubt on the sulfonylureas and the magnetides?
Yes, sir. Is the weight gain physiological or psychological?
Is
The weight gain for sulfonylureas, is it like is it the whole I'm hypoglycemic and so I will eat more food?
yeah, both things.
Okay.
First thing, the insulin itself can cause a weight gain, and second thing, because of the behavioral changes, the patient will eat more diet so they can get the weight gain. Both things.
All right, thank you.
Okay, and yeah,
Glitazones causes bladder cancer.
please repeat it again.
You have wrote glitazone
Where?
cause of
Glitazones.
glitazones.
Okay.
They
Yes.
cause bladder cancer.
Yeah, for the long-term use. Although I've never encountered any question, it was just a fact which I've seen somewhere that for the long-term use, they can even cause the cancer, the glitazones. Not much important for the step one, don't worry about that. The important part is the edema only, the volume overload, okay? It's just a fact, if you want to remember, you can remember it, that they can cause a bladder cancer in the long term. But I have encountered no question on this fact, so yeah.
Okay, thank you.
Okay, then comes the increase in the glucose-induced insulin secretion. Very important because it is the glucose-induced insulin secretion. So whenever you have a low glucose, insulin secretion will be inhibited. So with these drugs, you can never get a hypoglycemia because the release of insulin by these drugs is totally dependent upon the glucose. If low glucose is there, the glucose secretion by these drugs will be inhibited. So that's why no hypoglycemia in both of these drugs. One is the GLP-1 analogs. Whenever you take a food, okay, and you take the food by the oral route, not by the IV route, okay. So whenever the food reaches to your GI tract, okay, it will cause the release of this GLP-1, which is a protein, okay, that causes the that causes the glucose-dependent insulin release, okay. So you have made the analogs of this GLP-1, okay, like the exenatide and the liraglutide, okay, they causes the again glucose dependent insulin release whenever you take the food, okay. And what other things they can do? They will cause, first is a decrease in the glucagon release. Of course, if they increase the insulin, they will decrease the glucagon. Second thing, they will decrease the gastric emptying, and by decreasing the gastric emptying, they can cause the early satiety, okay. They will decrease the appetite, it will cause the early satiety, and it can cause the weight loss, okay. So three things: the glucose dependent insulin release, the decrease in the glucagon, and decrease in the gastric emptying to provide the to cause the early satiety. So these three things should be there in the GLP-1 analogs. The important side effects again include the nausea, vomiting, and the pancreatitis. Pancreatitis is very important, okay. These drugs can cause the pancreatitis, acute pancreatitis, okay. We will discuss all the causes of this pancreatitis later in the GI section, and one of them is the GLP-1 analogs. They can also cause the weight loss, which is because of the loss of appetite, because of the early satiety, right? Second ones are the DDP4 inhibitors, okay. DDP4 are the is the enzyme that basically metabolize this GLP-1, okay. So GLP-1 will be undergoing the metabolism by this enzyme DDP4, okay. So to promote the increased levels of this GLP-1, okay, you need to inhibit the DDP4, which is done by the drug, which is linagliptin, saxagliptin, and the sitagliptin. Every drug has the name gliptin in it, okay. Sitagliptin, saxagliptin, and the linagliptin, okay. They inhibit the enzyme DDP4 so that the GLP-1 could be activated, right? So similar to the GLP-1 analogs, they can cause the decrease in the glucagon. They can cause a decrease in the gastric emptying, okay, and they can cause a increased glucose-dependent insulin release. They can cause the early satiety, and the important thing is to remember they can cause the respiratory and the urinary infections. Very important, like the nasopharyngitis. Okay, so for the upper respiratory tract infection, you will always think about the gliptins. For the pancreatitis, you will think about the GLP-1 analogs. Okay. So any doubt on these two drugs, these two classes of drugs?
No.
Okay. Now then comes the drugs which decreases the insulin, which decreases the glucose absorption, either the reabsorption or the absorption. Okay. So first drugs are the SGLT2 inhibitors, and remember the SGLT2 receptors are found in the PCT of the renal tubules, right? So they're actually inhibiting the SGLT2 receptors, and when they inhibit the SGLT2, they causes a loss of sodium and the glucose, right? And because of the loss of glucose in the urine, they can cause the urinary tract infection. They can cause a vulvovaginitis, okay, which is by the candida. If you guys remember the microbiology lecture, we have discussed how the how the candidiasis of the vulvovaginitis it can be due to the high glucose, right? And second thing would be the use of any antibiotic, right? So they can cause a UTI, and because of loss of the fluid in the urine, they can cause the dehydration. It can cause the orthostatic hypotension. Okay, you can even have a hyperkalemia. Can anyone tell me why the hyperkalemia?
Is it because we can't shut off our the cells, the what is it, the calcium, potassium, sorry, I forgot what the
See,
gates are, never mind.
by inhibiting the SGLT2 receptors, you are actually inhibiting the RAS. Can anyone tell me why I'm inhibiting the RAS by inhibiting these receptors?
Because you're dehydrated?
No, because I'm increasing the sodium delivery to the macular denser cells. And remember, macular denser cells actually senses the sodium delivery to the DCT. If the sodium is increased in the DCT, the macular cells will be inhibited and RAS will be inhibited. Okay. And when the sodium reabsorption is much more, in that case, the RAS will be activated because the delivery of sodium is less to a DCT. Okay. So by inhibiting the SGLT2 receptors, so see, in the initial scenario, what was happening? I'm having a very high glucose, right? And because of the high glucose, I'm activating my SGLT2 receptors, so that more glucose and more sodium could be reabsorbed by the tubules. Okay, and when you causes the more sodium and more this glucose reabsorption, the delivery of sodium to the macular cells will be very much low. In this scenario, in the normal patient without any drug, in a patient with the diabetes without any drug, what's gonna happen? My macular cells will be activated and RAS will be activated, right? Is that okay? This is a normal scenario, the activation of RAS in the diabetes. Whenever you have a high glucose load, more glucose will be absorbed by the SGLT2 receptors. And because the SGLT2 causes the symport of the sodium and the glucose, sodium along with the sodium will be reabsorbed, right? And as a result, the sodium delivery to the macular cells will be decreased in the diabetes patient. And so they will get the activation of the RAS. Is that okay for everyone?
Yeah.
When you give the patient SGLT2 inhibitors, you're inhibiting the reabsorption of glucose and sodium. Now the delivery of sodium and glucose to the DCT is increased, and as a result, the macular cells will be inhibited. So what you will have is a loss of renin secretion. Is that okay?
Yes.
And because the renin secretion is lost, the renal hyperfiltration is also lost. Because whenever the renin is activated, it will release angiotensin 2 that can cause the vasoconstriction of the efferent arterioles to promote the hyperfiltration, right? I'm inhibiting the angiotensin 2 by inhibiting the RAS, and now I am having a very low renal hyperfiltration. Is that okay?
Yes. Okay.
And this is a question of my step 1. Okay, they have asked me what changes can happen when I give the patient SGLT2 inhibitors, and this is to decrease the renal hyperfiltration, a very important thing. Why does it happening? Because I'm inhibiting the SGLT2, I'm inhibiting the sodium delivery to the macular cells. Okay, I'm inhibiting the RAS and I'm inhibiting the renal hyperfiltration. Okay, do not forget that. Is that okay for everyone?
Yes. Okay.
So now the side effects we have discussed. You will have the glucosuria. Okay, you will have the UTI. You will have the hypotension because of dehydration. Okay, and you must use these drugs very caution with the renal insufficiency, because if your kidneys kind of failed okay, then you have a very low GFR. And because these drugs are acting on the kidney, if they cannot reach to the renal tubules, how they can act, right? So in case of a renal insufficiency, because GFR is already very much low, these drugs cannot reach to the tubules and they cannot do their job, right? So before prescribing these drugs, you always need to check for the renal function test. Just like your metformin, you need to check the renal function test or the creatinine level before prescribing these drugs. Is that okay?
Yeah, cool.
Okay. So now comes the alpha glucosidase inhibitors, which are found in the GI tract. And these are the acarbose and the miglitol. Okay, they inhibit the brush border alpha glucosidase, which causes the hydrolysis uh, of the polysaccharides, right? So by inhibiting the drugs, you are not digesting your polysaccharides, and because you know only monosaccharides can be absorbed in the GIT, not the polysaccharides. Okay, so polysaccharides will be lost in their stools. Okay, so what you will have is a postprandial hyperglycemia. It will cause a GI upset. It will cause the bloating. Okay, and it is also not recommended in the renal insufficiency, because in that case you will have a too much level of these drugs. You can have a too much of the diarrhea, of the bloating, and other symptoms also, and the hypoglycemia also. Okay, so they're actually useful in decreasing the postprandial hyperglycemia. They can cause the hypoglycemia. Okay, any doubt on this alpha glucosidase inhibitors? Very much easy. They just inhibit the glucosidases. Okay. Is that okay?
Yeah, it's okay.
Yes.
Then some other drugs like the amylin analogs, which are this pramlintide. Okay, and does anyone remember the amylin?
Yeah,
Where
it
we
was
are
being
studying?
released by beta
Yeah.
cells.
Okay, and what does it cause in case of type 2 diabetes mellitus?
Amyloidosis.
Yes, it was amyloidosis, or secondary name of this amylin is iodide amyloid peptide, IAPP. Okay, step 1 can give you any of the name. So this drug can decrease the glucagon release, can decrease the gastric emptying. It can cause the hypoglycemia, early satiety that can cause the weight loss. Okay, nothing much more important about this drug. So we have finished with this page. Any doubt on this page so far?
Yes, sir. I'm sorry. I had one problem.
Yes.
To the SGLT2 inhibitors, so it's this the point that you made at the bottom of your page, that I understand, but I don't understand your top point. It says due to the SGLT2 sodium delivery. I thought when your sodium is going to be more at the macula densa, your body knows that you have high osmolarity, and so you need to bring in.
It's not about my body, it's about the macular cells. They cannot sense anything but just the sodium. Okay, if I increase the sodium to them, they will be inactivated, and if I decrease the sodium to them, they will be activated. Okay, they have only one receptor for that. And
Okay,
if they're
so
activated, yeah, they're just dependent upon the sodium delivery. Doesn't matter anything else.
okay, so high sodium to them reads as high blood pressure.
Yeah, exactly.
Okay, thank you so much.
They don't know about my body in any way. Okay, they're just dependent upon the sodium delivery. If the sodium is more, they will be inactivated. If the sodium is less, they will be activated. Doesn't matter the BP is, and doesn't matter what the volume is of my body is. Okay, they just the only thing that matters to them is the sodium. Okay.
Perfect, thank you.
Then comes the drug for the hyper and the hypothyroidism. Okay, first ones are the thianamides, the propylthiouracil, and the methimazole, or other drug is the carbimazole. Okay, these drugs, they're actually the inhibitor of the thyroxine release. They inhibit the enzyme which is the thyroid peroxidase, and you guys already know that this thyroid peroxidase is responsible for the organification, coupling, and the oxidation step of the iodine, right? So these three steps will be inhibited, and what you will get is the low release of T3 and T4. This propylthiouracil, it has a special ability. It can also inhibit the 5-deiodinase, and so that decreasing the conversion of T4 to T3. Okay. So yeah. So what would be the clinical use? Clinical use would be the hyperthyroidism. Very important. Okay. And another very important thing is that this propylthiouracil, it is a very highly hepatotoxic drug. Okay, and this methimazole is the what do you say? Just give me a second, guys. Yeah. So this the PTU is a highly hepatotoxic drug, and the methimazole is a highly teratogenic drug. Okay. So you cannot give the methimazole to a first trimester patient. Okay. Any female who is pregnant and and she is in the first trimester, you cannot give the patient methimazole because it is highly teratogenic, and all the teratogens, they act mainly in the first trimester. Okay. So for any pregnant female, okay, you always gives the propylthiouracil in the first trimester, okay. But because this is a very hepatotoxic drug, you cannot give it for a you cannot give it for a much longer duration, right? So just after the first trimester, you stop this therapy, the PTU, and you switch the patient to the methimazole, right? And this is to prevent the hepatotoxicity. Okay, so for any pregnant female, okay, you first give them PTU in the first trimester, and when the first trimester is over, you give the patient methimazole to prevent the hepatotoxicity. And you cannot give the patient methimazole first because it is highly teratogenic. Okay, very important. And it is not used to treat the Graves or ophthalmopathy. And you guys already know, because in the Graves disease, it is the autoimmune condition. It is the antibodies which are responsible for the edema behind the eye, the exophthalmos. All right. So to treat the ophthalmopathy in case of Graves disease, you need to give the patient glucocorticoids, not these drugs. Okay. So yeah, and third thing would be the adverse effects, like we have discussed. Agranulocytosis is a defect for the methimazole, mainly aplastic anemia. Okay, the hepatotoxicity is the main side effect for the propylthiouracil. Okay, and the methimazole is a possible teratogen that can cause the aplasia cutis also. Okay, and for the agranulocytosis, the neutrophil count will be lower than 500. And whenever you have a low neutrophil count, invasive infections by the Candida, by the Aspergillus, and by other bacteria can happen. Okay, so you will get the fever, and because you have no neutrophil in the blood, right? And if you have no neutrophil, okay, then it cannot cause much inflammation, right? Symptoms are always very much milder. Okay, generally only the fever, or chill sometimes, or sometimes a sore throat. Symptoms are very milder, not a very severe, because you do not have the neutrophils to cause the inflammation, right? So yeah, that would be all about the thionomides. Any doubt?
No, thank you.
Okay.
Wouldn't
Yeah.
methimazole affect the fetus? Like it's teratogenic.
See, all the teratogens, they mainly affect only within the first trimester. Okay, when the organs are developing, when the organ changes were happening. Okay, once the organs are developed, now only the growth will happen, right? And teratogens has no effect on the growth. Okay, they just affect the organogenesis process, which is happening within the first trimester. Okay, so you need to avoid all the teratogens for first trimester only. You can give them after the this part is over. Okay. Okay, then comes the treatment for the hypothyroidism, which is a replacement therapy, hormone replacement therapy. And these are the levothyroxine and the leothyronin. The levothyroxine for the thyroxine hormone T4, and the leothyronin for the T3. Okay, and they're very useful for the hypothyroidism, for the mixed edema. Why? Because the thyroid hormone is responsible for the clearance of the GAGs. Okay, that can treat the mixed edema. And because they can cause the hyperthyroidism, they're generally abused for the weight loss, because one of the feature of the thyroid hormone is to promote the metabolic rate, is to increase the metabolic rate, right? So they can cause the weight loss also. Okay, so you always need to distinguish between the exogenous thyroid intake and the hyperthyroidism. Okay, and this is and this can be done by the biopsy of the patient's thyroid gland. Okay, and second thing is the radioiodine uptake. Okay, and third thing you can do is the thyroid blood flow. See, whenever you are having an endogenous release of the thyroid, okay, so in that case, the thyroid gland must take the iodine increase amount. Okay, the blood flow to the thyroid must be increased because of the hyperplasia thing, right? So whenever the patient is having an endogenous release of the thyroid, the iodine uptake must be increased and the blood flow to the thyroid must be increased, right? But whenever the patient is taking an exogenous thyroid, then in that case, atrophy of the thyroid gland will happen. So if you check for the biopsy, you will find the atrophy of the thyroid gland. Okay, first thing. Second thing, because endogenous production is not happening, the radioactive iodine uptake will be decreased. And third thing, the blood flow because of the atrophy is also decreased. Okay, very important. So then comes the side effects, okay, or the adverse effects. Adverse effects are because of the hyperthyroidism. This is the tachycardia, heat intolerance, tremors, and the arrhythmias. And arrhythmias can lead to the death of the patient. So if step one give you a history of the patient who is kind of who is abusing these drugs for the weight loss, okay, and they will ask you what could be the complication or and what could be the death of what could be the reason behind the death of this patient. So this would be the arrhythmias. Very important, don't forget that. Okay, symptoms are all because of the hyperthyroidism. And they can also ask you the TSH levels, the T4 levels, and T3 levels after giving these drugs. If you give the patient T3, okay, which is a leothyronin, then in that case, the T4 will be low and the TSH will be low. If you give the patient T4, which is a levothyroxine, the TSH will be low, but T3, T4 will be high because T4 ultimately converted to the T3. So both T3 and T4 level will rise if you give the patient thyroxine, but TSH will fall. In case of leothyronin, the T4 TSH will fall and the T3 will be increased. Any doubt on these two drugs?
No, thank you.
And the hypothalamic or the pituitary drugs, one is the tolvaptan, conivaptan. We have discussed that these are the antagonists to the ADH. Okay, so you use them for the SIADH. Okay. Third is the demeclocycline, which is a modification of a tetracycline. Very important step. One can ask you this fact: that demeclocycline is an analog of a it is a type of tetracycline drug. Okay, it is a tetracycline. We have modified it, and it is also having the ADH antagonist property. Okay, all of these two drugs can cause the diabetes insipidus, which is nephrogenic type, by blocking the ADH receptors. Okay, then comes the desmopressin, which is a ADH analog. Okay, it is useful for the central diabetes insipidus, and because you know that the ADH also increases the von Willebrand secretion, okay, which carries the factor 8. So these drugs are also useful for the von Willebrand disease as well as hemophilia A. Okay, because they promote the water reabsorption in the tubules, it can be useful for the treatment of sleep enuresis. Okay, then for the growth hormone, it is used for the growth hormone deficiency and the Turner syndrome. Why in the Turner syndrome? Can you even tell me?
Turner has a short stature.
Yeah, and can anyone remember the name of the gene which is responsible for the short stature in Turner syndrome? Does anyone know the gene name which causes the short stature in Turner syndrome? It is the SHOX. Okay, don't forget that. These are the SHOX gene, which is the short stature in OX. And you guys know that OX is for the Turner syndrome, right? So short stature in OX or the SHOX. This gene is responsible for the short stature in the Turner syndrome. Okay. So you use a growth hormone to promote the height of the patient, right? Third is the oxytocin. Oxytocin is generally used to induce the labors, okay, and to control the uterine hemorrhage. Whenever you encounter a patient who is having a postpartum hemorrhage, first thing you will do is the uterine massage. If the uterine massage are failed, then you give the patient oxytocin. Okay, if the oxytocin is failed, then you have to cleave the blood supply to the uterus to prevent the blood loss. Okay, so oxytocin is one of the agent that is used in the postpartum hemorrhage. Okay, now third thing is the octreotide or the the last drug is the octreotide or the somatostatin. Okay, which is useful for the acromegaly because it inhibits the growth hormone. It is useful for the Carcinoid syndrome. It is useful for the gastrinoma, for the glucogonoma, and very importantly, it is also useful for the esophageal varices because it causes a vasoconstriction and it will decrease the blood flow to the esophagus, right? So that's why octreotide is very useful for the treatment of esophageal varices. And any other drug which is useful for the treatment of esophageal varices?
Beta blockers.
Beta blockers. Very important. Okay, don't forget that. Then comes the steroid, which is the fluorocortisone. Okay, it is a synthetic analog of the aldosterone with a little glucocorticoid effect, generally useful for the primary adrenal insufficiency, for the mineralocorticoid replacement. Okay, adverse effect, it can, because it has a little glucocorticoid activity, it has an adverse effect just like the glucocorticoids. It can cause a central fat, peripheral wasting, okay, and the poor wound healing, high BP, high glucose. It can also cause the edema because you're having an exogenous aldosterone. Then in that case, the aldosterone escape is inhibited, okay, and when the aldosterone escape is inhibited, you can have the edema also. So it can cause the exacerbations of the heart failure because it will cause a further volume overload on the heart, right? And it can also cause a hyperpigmentation. Can anyone tell me why hyperpigmentation?
Increased synthesis of ACTH because of
Yeah.
no negative feedback.
Yeah, exactly. Okay, so remember these the side effects, remember the use, and remember the type of the drug it is. Okay. Any doubt on this page?
No doubt. Thank you.
And one important thing that I want to tell you: whenever you encounter a patient with a with a thyrotoxicosis, okay, with the acute failure of the hyperthyroidism, the first thing you will give the patient is the beta blockers for the instant relief of the symptoms. Okay, you cannot give the patient the thionamide drugs. Why? Because they always takes time to act. Right. So whenever you encounter a patient having a thyrotoxicosis or the acute flare, you always give the patient beta blockers first. Okay, very important. And for the radioactive iodine, as a treatment for the hyperthyroidism, you always give them with the beta blockers, because what happens is sometimes in the early treatment, okay, the radioactive iodine as a treatment, they will increase the thyroid hormone in the early stages. Okay, so if you're a physician who is giving a radioactive iodine therapy to the patient with a thyroid cancer for the hyperthyroidism, okay, you always give it with the beta blockers, because in the early stage of the treatment, it can cause a paradoxical increase in the thyroid hormone. Okay, are we good?
Yeah, we are good.
Okay, now comes two more drugs, which are the cinacalcet and the sevelamer. Cinacalcet, if you remember, sensor, which is a calcium sensing receptor in the parathyroid gland and in the DCT. Remember, which senses the calcium levels, and whenever the calcium levels increases, it will inhibit the PTH, right? And you remember one syndrome associated with it, which is the hypocalciuric hypercalcemia, right? Remember?
Yeah.
And what kind of sensing receptor it is? Voltage gated or the G protein coupled?
GPCR.
Exactly. Okay, don't forget that. So basically what happens, it is present on the parathyroid gland. Whenever you give the patient this drug, it will sensitize the calcium sensing receptor and it will inhibit the PTH. So it could be very useful for the secondary hyperparathyroidism, if, especially in the patients with the chronic kidney disease who are receiving the hemodialysis. It is useful for the hypercalcemia in the primary hyperparathyroidism also. Okay, it is also useful in the patients with the hypocalciuric hypercalcemia. Okay, adverse effects includes the hypocalcemia. Other drug is the sevelamer. Okay, its function, see, it is a non-absorbable phosphate binder. Okay, what happens whenever you take this drug? Okay, it will bind to the phosphate in your GI tract. Okay, and when it bind to the phosphate, okay, the phosphate cannot be absorbed from your GI tract, and as a result, it will be lost in the stools. So this is the function of the sevelamer. Okay, it can cause the it is useful for the hyperphosphatemia in the chronic kidney disease, and it can cause the hyperphosphatemia and the GI upset also. Okay, other non-absorbable binders are also available. Okay, these are the patomer. Okay, which has an action same as that of sevelamer, and the second one is the sodium zirconium cyclosilate. sodium zirconium cyclosilate. Okay, see all of these agents, okay, they bind to this drug, they bind to the potassium, and they can cause the loss of potassium. Okay, yeah, that would be all. Any doubt about the cinacalcet or the sevelamer?
No, thank you.
Then comes drugs for the obesity. Okay, although you will study them later in the GI section also, but we can discuss them here again. One are the sympathomimetic amines. Okay, these are the phentermine, the diethylpropione, and the benzphentamine. Phentermine, diethylpropione, and the benzphentamine. Okay, they basically stimulate the sympathetic agent, the sympathetic system, and they can cause the inhibition of the reuptake of norepinephrine. Okay, the serotonin as well as the dopamine. Okay, so basically there is yeah, that would be it. So they're only useful for the short period of actions, and the patients who are having a CVD or any kind of this cardiovascular disease, you will avoid these agents in those patients. Okay, so they are central appetite suppressants. Okay, and they also causes the increased release of norepinephrine, serotonin, and this dopamine. Okay, so they are only useful for the short period of time. Okay, and they are not recommended for any patient with the cardiovascular disease. Then comes the orlistat. Orlistat is an inhibitor of intestinal lipase. So they actually inhibit the lipases. That's why inhibiting the fat absorption in the GI tract, fat loss will occur. Okay, although it can cause the intestinal discomfort because of the steatorrhea and the diarrhea. Okay, third drugs are the bupropion and the naltrexone. The combination of these drugs are given. Okay, and they can also promote the weight loss. Okay, and fourth one are the inhibitor of the neuropeptide Y. If you guys remember, the neuropeptide Y actually causes the increase in appetite. If you inhibit the neuropeptide Y, it can cause the loss of appetite also. So these are the agents which are useful for the obesity. Step one will ask you, they will give you certain mechanism in the question stem, and they can ask you the drug name associated with it. They can give you certain, for the orlistat, they can give you the side effects, in the patient, the diarrhea, the GI upset, bloating, and the fat malabsorption. And they will ask you what drug he or she might be using. This will be the orlistat. They can give you a history of the patient with the depressions or any something like that, and they can ask you, and they will also give you the action of the drugs, and they will ask you the name again. So just you need to remember the mechanism of action, and second thing would be the name of the drug. Okay, phentermine, diethylpropione, and benzphentamine, the orlistat, bupropion, and the naltrexone, they're all useful for the weight loss. Is that okay?
Yes, okay.
Okay, so with these facts, your endocrine is completed now. Okay, from tomorrow we will study the GIT. Okay, and we will wind up here for today. Okay, my throat
Okay.
is not okay.
Okay.
Thank you. Take care.
Thank you so much, everyone.
Thank you very much.
Thank you.
So much.